citizens who are in this room, that people who feel that we are not at the right place and we need to put our efforts together. And so, Grace, you are our epitome for now. You stand with us. We respect you. And I would like all of us here to just take a minute of silence. And when I say amen, we say thank you, Grace. Amen.
Thank you, Grace.
Welcome. Have a seat, please. So I'm privileged to stand before you, especially at this time when the country seems to have developed a good sense of intolerance. That we are at this time saying that things aren't the way they're supposed to be, and we have the opportunity to take that chance and make our voice known. We have that opportunity also to say that as a country, we have systems, we have institutions, we have people, and people need to do what is right. And as citizens, right holders, we have a right to complain, and not just complain, but complain bitterly. The reason for that is because when you look at Grace and many others out there, especially in my rural home in Kakamega, I have gone to some of those health centers and found women, children, who have come and they cannot access treatment. While you go back to the Constitution, Article 43, you realize that it gives all of us an opportunity through our rights, which are not negotiable. If you go to the Universal Declaration of Human Rights, 1948, it gives us 4 principles that we must always look at. That this is universal, it is interdependent, it's inalienable, and it cannot be divided. And therefore, we cannot say on one hand, we are giving you a road, and on the other, we are denying you medical treatment. Those two things must just happen because we have moved away from needs-based approach of things, and we took a rights-based approach. And rights-based approach simply means that the government cannot wake up this morning and say, we have no resources. And I say this with a lot of humility. Part of it is because I have seen cancer patients. I have lost 3 patients at a personal level. Brothers and a father. For the simple reason that the hospitals were unable to treat these particular patients. So coming back here and looking at where we are as a government and where we are as a country, and you can see the debate, the discourse that was once NHIF. It has morphed into SHIF, it has morphed into SHA, but all these things happen because we have people in leadership who have decided that they can do what they deem fit for them and not necessarily for this country. The intention of law development is to cause some social engineering. But then we cannot say we are causing social engineering when we are actually subjecting many people to suffering. The question that this forum needs to be asking, was it necessary? Was NHIF transition necessary? We need to ask that. We also need to ask, what are these things we are supposed to do? And especially when you look at, I have had CHPs in this room, I've had paralegals in this room. What will be so terrible or difficult to continue something good that your predecessor has begun? Why is it that we always want to reinvent the wheel and in the process cause a lot of duplicity and in the process waste a lot of resources just because we want to be unique? And if you walk this country, you'll see many, many projects either by CDF that have been left abandoned simply because the people did not find it valuable in their political mandate. So as we move with this, I would like us to be asking whether health governance in this country is alive to what Article 2, Sub-Article 4 and 5 and 6 speaks to us about, that we have made commitments as a country to ensure that everyone has a right to good health. But closer to that is the Declaration on the Right to Development of 1986 that demands that it doesn't matter where you are, It doesn't matter your geography, neither your ethnic identity or gender identity. It simply means that you have a right to development wherever you are, in whatever state that you are in. But even as we discuss that, maybe you need to be asking yourself, for us who saw what happened at Kenyatta on Thursday, we are aware what happened, isn't it? That is an institution where people are supposed to go and be treated. But that's where people go to die, not because they have not been treated, because they have been killed. We need to look at all those issues and to contextualize them in where are we in terms of general governance, but importantly, what is our health governance telling us? The other thing I think we need to be asking is, what is the role of stakeholders, especially when you have a government that is very intolerant, that you can't criticize this government. But it's the same government that tells you that they don't know who is doing what and everything is happening anyway all the time. Those are questions we need to be asking ourselves, especially when you think that 40-something young people have been arrested in Isiolo. And I'm using the word arrested with a lot of cautious, because they could actually be abducted. So having said that, I would like to recognize the fact that we are in this room today, and we need to address several critical questions. So one of the questions we need to be answering is, how can you ensure that health financing mechanisms like SHIF are effective, transparent, and equitable? I like saying that Kenya suffers two major challenges that are within both institutions and in people. We have systemic challenges that we have handed over and over for many years. But you also have attitude challenges. And those attitude challenges sometimes come through with questions like, do you now have a PhD? Those are attitude challenges that we need to understand that we're in these positions because we were elected in those positions, and it comes with a particular mandate that we must live up to. If we can't live up to that, then you have no business being in those places. Please don't remind us of how many PhDs you have. Dr. Mkangu is here. I've not asked him how many. Because we did not elect you for you to tell us about PhDs. We elected you to serve us. And not just serving us, but rightly serve us. What is the role? Should accountability mechanisms happen, both legal and institutional, when you are safeguarding the right to health in this country? What is our role? And so what is the role of people in institutions? And I'm happy the Council of Governors, where Dr. works, has been on that, because health docket has been what? Has been devolved. But the question I'm asking is, when you are devolving health, did we give it the prerequisite resources? What is the intergovernmental relations that we need to deal with? When you talk about 15% that we can use freely as county governments, what happens to 85%? What is so big that 85% is doing? I was in Parliament the other day, and my good friend, Honorable Tika Juang, asked me why I'm behaving like an activist. And I reminded them that these people you are calling activists are the people who love this country. They love this country, they care about the Constitution. They love this country, they care about the mamamboga who is at home. They care about that boda person who has not gone to school, but requires some livelihood. And so they were telling me they can't touch 85%. And I was saying, oh goodness, what a waste. We have sold this country through the parliament, which is supposed to give us the protection that we require as a country and as a people. The next question we need to be asking ourselves is, how do we strengthen public participation in these processes to ensure that we have not only participated, but our voice and concerns have been adopted? It is only when we get angry, and we get angry, all of us. Gen Zs got angry at some point, and I would like to share in this platform that in 2004, when we were organizing some protests in this country, young people then, who maybe are my age now, asked me whether I have been paid to go and protest. This time, as I sympathized with them and gave them solidarity, I asked them, who paid you? Who paid you is the difficulties you're going through, isn't it? It is the anger, it's the hunger, it is the lack of basics that takes you to the streets. So we need to be paid so that all of us can get angry and go out there and state what you have to state. The other question then will be, what are the immediate policy actions that are needed to address the current inefficiencies within the governance system? And so we are fortunate today because we have a medical professional amidst us who will help us understand what does it take to deliver health and medical care services in this country. We have a litigation strategist who will also help us understand what is the law, what does it say, what are the gaps, what are the inadequacies, what are the strengths, what can we do. When you're talking about law, I'd like to remind you of US, and I'll not talk about US in the context of USAID, but I'll talk about it at some before I finish, is that the same constitution that Barack Obama used, the same constitution that Biden used, is the same constitution that George Bush and Trump are using. But you can see the result, isn't it? The result is quite different. And so sometimes it's not about the law. It is about people who use that particular law. And I would like to remind you that we have a culture around law in this country. How many of us were in the traffic jam today morning? What did you see that is so peculiar, but common in Kenya? Overlapping. And when this person overlaps and they find the other person who's been following the queue, do they expect to be given way? Do they demand? Do they abuse you when you don't? That is our culture around the law. We must just change that. That if the law is a good law and it demands that all of us queue, let us queue. It doesn't mean that you can't protest a bad law. It means that a bad law must be protested, but we cannot misuse a good law just because we have our attitude issues that we carry ourselves with. We also have a public finance expert in the room who will help us, community movement champion, and community members with lived experiences of how the system has messed us up. Having said that, I would like to kind of craft a context of what we want to talk about. If you look at the auditor's reports in this country, look at the Office of the Control of Budgets, do you find the courage and the energy of working on the streets? Because the reports are really grim. That we have resources that is constantly and progressively misused and abused, isn't it? And we don't seem to get anywhere with that. The report comes 2025, 2024, 2023, and likely 2027. We're talking about the same thing, but no caveats have been put in place. We cannot talk about health, even with the good experts in the room, if we don't look at the geopolitical issues that are currently happening. I think we're already saying that people living with HIV, or people with HIV, are already facing problems. I was listening to Kingange, I think it was yesterday or today morning, and he said, and I don't know why he targeted Kisumu, he said, watu wa Kisumu mechi zipungue. Did you hear that conversation? Mechi zifanye nini? Why? Because condoms are not going to be available. And that is an effect of the geopolitical issues that we're dealing with. Trump has simply said, you said must do what? Must close shop. And I saw a clip where they were even removing the name of USAID from a building in the US. Meaning that if we have relied on resources, and I'm happy county governments are represented, from the diaspora, whether from bilateral, multilateral, or from our own people, it means we must sit down and rethink, isn't it? The second thing is that we have not learned from the KEMSA scandals. And particularly because the KEMSA scandals came about when we had COVID-19. And COVID-19 was a response to issues of vaccinations. The person in charge of that docket in the US is JF Kennedy, who doesn't believe in vaccinations. I don't know if you're aware of that. The question is, what kind of geopolitical relations are we going to create to ensure that our resources are used well without us having to go and beg? The other thing I think I would like to talk about is we behave as though COVID-19, whether it was true or falls did not happen because the challenges we faced then with the elderly people, with children, with women have not been addressed. And you never know what will happen tomorrow. So having said that, we go back to the law and we ask, so what have been our commitments as a country? We have committed internationally, we have a constitution that is progressive, we have institutions that we put in place, and we hope that all these things put together, they conspire to ensure that all of us have a right to access healthcare of good quality. I know young girls right now who will not be able to go to school because they're depending on USAID to get their pads. I know young people right now who will not go to school, partly because they are young mothers and there's nothing else that can be done. And I don't want to think like Magufuli, the late, God rest his soul in peace, who said, once you are a mother, you are a mother. But I'm bringing all these scenarios for us to do some soul searching and to agree that this country at the helm of health is at the wrong place, especially when we can arrest and torture the people who speak against what is medically and health-wise intolerant. God bless you.
Thank you very much, Eric, for that wonderful speech and context, which will set the stage for our discussions, which now is the next stage for this forum.
Landed there. I'll make a very short, brief story. My father was operated. He had a brain surgery, and he died because the hospital didn't have an ICU. So when he was being operated, I was not around. When I arrived, I found him gasping. Those are the last breaths that somebody takes, and he was on oxygen, and my mother was at the bedside. She didn't know he was dying. And I found the nurses taking tea. So it's a recollection when I saw these others taking tea. So it is a kind of a trauma. And he passed. They had no ICU. So when I asked them, can you take him to ICU? Do you have an ambulance? They didn't even have something called a resuscitation tray. When somebody is going, there's something we do. We help somebody to come back. So I watched him die. The second trauma I had was my mother. She fell in the bathroom and she was put a plate. It didn't catch. It didn't heal well. So the doctor said that we need to put another plate, take you to ICU because she was elderly, and then take you again to theater, take you to ICU. So she refused. And she stayed in bed for 3 years. Then finally, when she accepted to go, her option was, you take me to India, you will not operate me in Kenya. So we made arrangements for her to go to India. And while we were making arrangements, my husband also had been having issues with his stomach, and his appendix was removed. We found out it was normal, and so there was no need at that time. Later, his arm started paining. They did a biopsy. They found that he had cancer, stage 4. So the cancer had been eating him for years. And he kept going to hospital, being given medicine because he was having stomach issues. So while I'm taking my mother to India, at the same time, I'm taking my husband to India. So we went to India, we were treated. They took my mother to theater, they put a plate. But before she left Kenya, she broke her arm. We had been told by the doctor that there's a problem with her bones, and she was done something called bone density bone scan. Many tests were done to test her bones, and she was told they are normal. So when we reached India, after putting the plate is when we were told she also has cancer. So she died in India, and as we were left there. So now, 3 days later, my father-in-law died. So I was burying my mother, and I was burying my father-in-law. Anyway, we finished that. I started getting chest pains. I was taken to the best hospitals in Nairobi, wherever, Kenya, let's put it that way. They did tests on they told me there's nothing wrong with my heart, I'm good. And I kept getting worse. They gave me some drugs for TB, I reacted. So my husband told me, let's go back to India. When we went, I was told that I have a heart block. As there were two of my vessels that were blocked, so I was operated I have 2 stains right now. We are talking because of stress. And then my husband also was told that he has colon cancer, so he had to be operated. SHA, that time it was NHIF, it paid for everything. It paid the surgery, it paid the chemotherapy, it paid everything. And for me, because we didn't have money, the Kenyans paid for me, my surgery. So here I am in bed, me and my husband, in ICU, both of us. And there were some people who took care of us in India, a Russian and a Nigerian. We came back to Kenya. And after that, my sister got sick. She was done a brain surgery. It did not succeed, so she was taken to another private hospital, and they kept operating on her. When I consulted back in India, because I still had contacts of the doctors, they told me that there's no need of operating because her brain is already gone. But here in Kenya, we continued operating her. And the doctors kept saying there is hope, but me, I already knew, but I couldn't tell the others because you see, when the doctors are telling them it is possible, and here I am saying it is not, they continued operating. We had a bill of about 3 million by June. So she died in September. So 3 months down the line, we have a bill of 24 million. We wondered, 7 million per month, what are you doing? What treatment is this that you're giving somebody? 7. So right now we are talking, there's a bill awaiting of 24 million. Now, I go back to my brother-in-law. He got sick. He was admitted in that Kenyatta, and he passed in Kenyatta with cancer. There was also some things we saw, and I kept asking, I kept trying to intervene, and unfortunately he passed last year in December. So for me, it has been a journey, a pile-up of things happening to where I was. So me, after burying my brother-in-law in December, my leg was paining. So I already knew how the system of SHA works, because every time they had to operate my sister, I used to walk down to the NHIF. If the systems are down, there is another office called pre-authorization office, and they would be able to access the portal. So that was my life for a whole year. I used to walk down to NHIF to get the surgeries approved. So that day, I had been done an X-ray, so I was told you need to do an MRI. So I landed in Kenyatta. I talked to the patients who were there. We walked up and down the whole place. None of them was working. So I went to the offices that I knew in NHIF, and I asked the few people who could work with me to us. I could get them assisted, so we get an approval done. And that was a Wednesday. I had gone on a Wednesday. We spent a whole day there, and they were not working. And I went home. We actually prayed that day. The other people now they were giving their stories and had come from Bugoma. That's all over the country, and some of them were sleeping on the floors in Kenyatta. Others did not have food. Me, normally I have a motto that when I go to hospital, I carry breakfast, lunch, and supper, because when I was in India, that food we could not eat. So I got used to carrying food. That day I saw mothers with children who were hungry, who did not have food. I had carried chapatis with tea. I gave them. A mother was telling me how she slept on the corridors with a baby. And Kenyatta is very cold. People who've been in Kenyatta know how cold it is. So it was very traumatizing to see what was happening. And so the next day when I went, at around 11, it was still not working. So that is when I told them, let's go down and see if we can get help. So when we walked down to the offices, I knew we were going to ICT. And we asked them, they told us from the previous week on Wednesday, the systems had been shut. Then I asked them, are you aware Kenyatta is not working? They said no. So I said, fine. So what next? I go to the pre-authorization office. Also, they are saying they cannot get access. They don't even know they are not working. So I asked them, please help us. What do we do? They go to Afya House, 4th floor. So that is how I ended up there. 4th floor, 5th floor, 6th floor, 7th floor. We were just looking for help. It wasn't a planned thing. And I believe in God's steps, because how I woke up that morning to go to Kenyatta, I went as a patient. I was not going to do anything. I was going to get treatment also. So when I walked in that office, the CS was not there. It was only the reporters, and they were taking tea. So that is when I asked them, are you aware the systems are not working? And that is where I kept repeating they are not working because we could pay. But anytime you tried to get access to the portal to get treatment, it was not possible. So basically from Monday, Tuesday, Wednesday, there were patients there who required emergency services. They were unable to get. I saw that child who was crying because of the coin. I saw this mother who was trying to walk. Actually, even until today when we are talking, she's still not well because she walked up and down looking for help and she had not healed. So there were many patients who were traumatized, and that is how I ended up in SHA. Now, when I went to the hospital, for those 2 weeks, I was in my house because I somehow I didn't go to hospital. Now, the day I walked in that hospital, I've been helping patients all my life. That is a calling I have. That's what I feel. My neighbor had called me the previous week on a Saturday, told me the mother had fallen in the bathroom. So I advised her to go to that hospital and none, and the mother was operated on a Monday. So that Thursday when I was going myself as a patient for treatment for my leg after being done the MRI. And when I walked in, I saw that same police officer. There's an officer I saw when I was in Kenyatta after people seeing me in the news, and he followed me, and I asked him, where do you work? Why are you following me? And when I saw him in Landnan, I felt very uncomfortable. But he told me he had a patient. So I cannot ask questions, what you're doing here. It is less than 20 minutes after that, the police officers stormed in. So I was bullied, I was harassed, I was dragged. I was psychologically, mostly it's the psychological abuse that is there because the intimidation that was there. And I tried to tell them to let my son come, to let my lawyer come, because I had called them to come and they refused. So they dragged me out of hospital. I was taken to three different stations, and they were not telling me why they were arresting me. They were not identifying who they are. They were not telling me where they are taking me. So it was a harrowing experience. And finally, when they took me to Capitol, is one of the ladies told me, actually, we want a statement about what happened in the ministry. Then I asked them, did you have to drag me, bully me, and I could have just called me to the police station. I can bring myself. I come, I write the statement. There's nothing illegal I've done. So that is how I ended up in the police station, and I was supposed to go to court the following day. They released me on the 10,000 bail, and from that time I don't sleep well. I still having chest pains because, as I said, I'm a cardiac patient. The pain is still there, and I'm scared. Actually, I've come with my son. I cannot walk around alone. I feel scared, and we went. They told me that they have withdrawn the case, but officially it is not withdrawn because I went to the police station and they told me they have not received any instructions. So we are still awaiting officially to be told that it has been withdrawn. So there was no communication between the ministry and the police. So right now, I'm just in a limbo wondering where I am because officially I have not been officially released. My extension is until Wednesday, so I don't know whether the ministry will communicate to the police because the police are saying there has been no official communication. So that is where I am, a scared Kenyan, an intimidated Kenyan, a sick Kenyan. And I can't go for surgery now. I don't feel safe. So I don't know. I'm praying for recovery and I'm praying that I'll be able to overcome this. Thank you.
Thank you, Grace, for that story. I guess what is running in our minds right now is how many Kenyans are thinking enough is enough. What is happening in the transition as the next issue. But allow me to go to Dr. Happily and what was said. And a lot of us are wondering what this transition really looks like from a policy perspective or even
I don't think that the transition was properly managed. Whether it was even necessary is another question. But as an advisor at the Council of Governors, working a lot on policy analysis, legislative analysis, I look at bills when they come, and I can tell you that we raised very fundamental issues when the four laws, the bills came up. The Social Health Act, the Digital Health Act, the Facility Improvement Financing Act, and the Primary Health Care Act. We raised fundamental issues, and number one, we said that the Social Health Act is trying to create three different funds. One of them contributory, two of them non-contributory. That is, the Primary Health Care Act Fund is non-contributory, but is supposed to be funded by the Exchequer. The Emergency, Chronic and Critical Illnesses Fund is also non-contributory and is supposed to be funded by the Exchequer. And so one of the issues we raised was that if these two funds are funded by the Exchequer, why would you deny a Kenyan citizen, a taxpayer, access from these funds just because he has not been fully registered and paid up under the Social Health Act? We say that would not be right. If this is these funds are receiving money from the government, let everybody access that, even if you are not paid up under the Social Health Care Fund. They wouldn't listen. We also raise questions of the big problem under the NHIF was how to enforce contributions from the people in the informal sector. And the minimum at that, under that act was 500 shillings. And we argued, and I will tell you that I think about 2003, myself and another officer from the Council of Governors and two officers from the ministry went for a training workshop in Nagasaki, organized by World Bank, on health financing. And I can tell you there were very good experts. And they told us in health financing, each country is struggling with the best method of pooling money to finance health. And they said there are two methods. One method is to finance health through general taxes. The downside with that, the problem with that, is that health is then forced to go to the negotiating table when budgets are being done, to negotiate with other departments. Quite often, the decision makers on budgets, people at Treasury, people in finance, do not understand the uniqueness of health. And so a lot of times they end up allocating to health less money than health requires. Many times, even that money, when allocated, the transfers are delayed, both to the county governments and subsequently to the health facilities. And many of us argue, and I've done this in the counties when guiding them to pass the Facilities Improvement Financing Act, that while in the Department of Roads and Transport, you can put a construction of a road on hold while you are waiting for money to be transferred. In health, you cannot do that. Health operates on an emergency basis and requires money to be available 24 hours a day. So that if an emergency arises, you can go and purchase what you need. And so that creates a problem with the financing health through general taxes. Now, those experts said the other method is insurance. But the problem with insurance is that it is founded on the concept of voluntary contributions, that you must contribute to be covered. And the experts said that in economies where, like ours, a large portion of the population is in the informal sector and are not salaried, it is very difficult to enforce contributions from the people in the informal sector. It is normally easy to deduct salaries from those who are salaried. But in Kenya, you need to know, if you check statistics, the salaried people are just about 20% of our economy. 80% is in the informal sector. But that's not to say those are poor people. Actually, some of the richest people in our country are in those informal sectors. And some of the poorest people actually are salaried people. And so those experts say, in a country will not be able to build a sustainable fund. And what happens is that in such an economy, we will wait when a member of the family is unwell. Maybe they have now said, you have been diagnosed, you need an operation, and they give you a booking in 6 months' time. Then the family says, can we go and register our mother? We start contributing. 6 months down the line, maybe you have contributed 6,000 shillings. The bill comes out 2 million. The insurance pays. Then you drop out, what health workers call adverse selection. Once you have been treated, you are healed, you drop out, you don't continue contributing. Now you pay like that for 3, 4, 10 people, the fund is not sustainable at all. Now, so when we were making this, so those experts say, then faced with that, many countries seek to combine a bit of taxes and a bit of insurance. And when it comes to taxes, they emphasized, with a large informal sector, go for earmarked taxes, mostly put on consumables. For instance, and I argued that we do have a tested example in Kenya called fuel levy for maintenance of roads. We are taxed fuel levy earmarked for roads. So the KRA collects that money and simply hands over to the bodies managing maintenance of roads. And so some of us argued, why don't we then go for earmarked taxes for health? If we can earmark taxes for maintenance of roads, why can't we earmark taxes for maintenance of our own health? And we don't have to to create a new tax. We may just go to that fuel levy and we say, if it's 16%, 10% will go to roads and 6% goes to health. You have no costs of collecting that money. The KRA just collects, calculates, and gives to SHA that money. For you to understand that, you will know that even if you don't have a car, you normally jump onto a boda boda. The boda boda, when the fuel goes up, they increase the fare. So as you jump onto a boda boda, you are paying for health at no cost of administrative costs, very low. So you could also go for what they call syntax, consumables. If we say things that cause diseases, sugar, sodas, our mothers in the village take a lot of tea. So when you buy sugar for her, if you put a small tax on sugar for health, as she takes her tea, which may cause her problems, she is already also paying for health. I argued this. I even asked the officer we were with in Nagasaki, what happened? I thought we had agreed this is the best way Kenya should go. Why have you people insisted on insurance? It is not going to solve the problems NHIF had, because the fund under NHIF was not sustainable, because people in the informal sector are not easily paying. I can tell you that SHA will not succeed. It will not become a sustainable fund until we accept that maybe we made a mistake at that point and we amend the law to go to what can raise a sustainable fund. And if you go for fuel levy, there may be someone out there who is not salaried but owns 100 matatus on the Kenyan roads. The moment these matatus are on the road, they are fueling, they are helping us to raise money for health, isn't it? And that person will be paying equivalent to his income from his matatu without you having to do this thing called prox means testing and so on. Now, we raised issues at the Council of Governors. Is there going to be capitation for levels 2, 3, and 4? You are saying these reforms you want to shift from over-concentration on curative services and go to preventive and promotive, palliative, and all that. And therefore you have to shift, we have to invest more in primary health care. If you don't pay capitation to the primary health care facilities so that they can invest in things like outreach, screenings, and all that, then you are not shifting to preventive. And my argument is that the intentions of our law may be very good, but the devil normally lies in the details. Now, when we developed the details on the tariffs, we have something there that is called capitation, but it is not capitation as we knew it. Because capitation was you give money to the facility up front, then the facility invests in that. Of course, health economists have been telling me that encourages the facilities not using that money in health. But then I was saying, okay, if that is the argument, then we must include in the capitation the services that are rendered at level 1 and perhaps link them to a level 2 facilities. A level 2 facility. I saw many community health promoters here. They have been given gadgets. Why don't you link them to the nearest level 2? So that when they deliver services in the community, they record those services, and those services are reflected as services rendered by level 2, which they are linked to, and then that level 2 claims for that money, and then it's able to invest back into the services. Now, those details we still have a lot of problems. And one problem we have with SHA is that when we raised these issues, and I must confess, when they didn't listen, the kinds of governors went to, someone went to court, of course, with some of our support, and judgment came. They said, you can't deny people emergency services because they are not registered under SHA. You didn't do adequate public participation. Go back and do. A meeting was called between the ministry and the council and the lawyers, and I told them, for once, why don't we do what the court is advising us to do? They said, no, we must appeal. So there is an appeal still pending in the Court of Appeal. Thank you, Will.
Thank you very much, Dr. for that comprehensive presentation and just giving us a picture of the ideal operation of how things should be. But let me just go to the medical professional, Dr. Kahura. Of course, we know that SHIF has affected healthcare delivery currently. And so from a medical profession perspective, is there a growing dissatisfaction in terms of the healthcare reforms that we are seeing from a medical profession perspective?
Well, thank you. And first of all, I want to begin by sympathizing with Madam Grace Mulay for her ordeals and experiences, because the state owes her a duty and a responsibility for her to access the highest attainable standard of healthcare. And that is what we passed on in the year 2010 in the constitution of that year. And these services exist for us as a people. And there is what we call as a citizen value proposition. So for all the persons that we put into office as our leaders in the politics, they're supposed to deliver their mandates as per the documents that guide the political landscape of that day. So today we live with aspirations that have not been fulfilled, and that's why we keep to talk as citizens, because we want the best for ourselves for the future, so that we enjoy better healthcare. And better healthcare means more time to do the best that we can do with ourselves to prosper and develop our country and to develop ourselves. So that is affected when the government does not do what we put it in place to do. So back to healthcare now. As providers, there are different kinds of providers. There's a provider who is a doctor, and there's a facility owners who are like investment partners or entrepreneurs in the healthcare business. They all have different kinds of expectations as to what they set out to do. The provider, that is a doctor, will set out to provide care to patients. It's the highest standard to the qualifications that that person is trained at. But now most of the time, as patients, we may not have money to pay for this healthcare. And because of that, we are supposed to either pay out of pocket, or someone with a system pulls money somewhere, either through taxes, the general taxes, or through insurance, and uses that system to pay for healthcare for you, so that the provider can give you services. So that experience does not happen because you are challenged with finances and you don't know what to do as a patient. On the other end, you have now the providers who set up the hospitals, the investors, and they bring in providers and they want to play in the system and provide the same things as the individual players. So these experiences don't take off when the financing structure is incompetent or it's having issues. And since 1965, that's like 2 years after independence, the government of that day decided to set off on a path to provide healthcare to Kenyans. And through what we call as a sessional paper of 1965, they set out to start the NHIF. So the H there meant hospitals. And it did work at that particular time in 1966. The NHIF was started as a department. Remember, it's a department in the Ministry of Health. And it did work all the way until 1998. So only in 1998 did it cease to become a department. And it was given the autonomy to act like a company, but a government company, which is a corporation, state corporation. And as a state corporation now, it's given more independence to pool funds. Remember, from 1966 all the way to that 1990, it was for employed people, mostly for the formerly employed in the public service And from 1990, the private employed persons were to make contributions there. And these contributions were not that much because maybe the rates of pay at that particular time were too low. So the funds were never enough, but they used to pay for the bed rates. What you used to hear as NHIF pays only for the bed. But as time went by, they wanted to improve and give the best to the people of the day. And there have been reforms in the journey since 1998, 2004 with the Kibaki government, but that did not take off again. And come around 2012, 2015, they said, let's revise the rates of increments to probably 150 shillings for the formally employed and 500 shillings for the voluntary contributions. So voluntary contributions starts around 2010, thereabouts. And they cap the maximum contributions to 1,700. And because of the new constitution, the new aspiration as a people, we wanted to give ourselves something. And we did work towards that. The management of NHI at that particular time wanted to achieve that for the people. And somehow they were making all these reforms. And it did work. KOTU tried to oppose the increments from 450 to 700 to 1700, but it didn't succeed. So that maintained. And come 2018, we have now the big 4 agenda, UHC. So it's a journey that has been happening over time. We are yet to arrive where we want to go as a people. So today as we speak, we have SHA, which is the authority. It's like the company board that manages our health benefits. And the health benefits are framed in the Social Health Insurance Act. So we have had, and we know by the facts by the Kenya Bureau of Statistics, that we don't have enough formally employed persons. And no matter how much you want to collect from these people, that money is not going to be enough. And the government itself is not giving in enough to the other 2 funds that it's supposed to take care of. And that means when we want to access services, and you've heard from the political rallies, healthcare is free. Just show up and you will enjoy the services. But when you show up, you have registered, but the services are very little. That means you still have to go to your pocket to pay for more. So there is a little bit of misbalance in how this financing and services is happening. And that now gets to make the provider not give you the best. Because the provider will wait to be paid and they'll say, I'll not give you 1, 2, 3. Your payer only wants to pay 1, 2. So I'm only going to give you 1, 2. And for the third item, you'll pay for yourself. So for yourself is cash or an alternative insurance to top up and meet the difference that the public insurance has not paid for. So when that becomes too costly, we will complain as a people. So in other countries, these systems work. Not many countries in the world, but they have attempted to make them work. You have the UK, you have Ghana that tried, you have South Africa which is trying, you have Gambia which has tried, but here they are doing communications tax. See the way you buy airtime, and you now have the road levy. That communication is also added a tax on it. And as much as you want to talk, call each other, transfer money, those levies accrue, they are collected centrally, and they're sent somewhere, and they pay and assure you for care. So now that when you come to the hospitals, we'll tell you now we can give you 1, 2, 3. The provider is happy, the hospital owner is happy because they've been paid. It's like a system. If you don't pay bills to the doctors, if you don't pay bills to the hospitals, then they will not pay salaries, they will not pay rent, they will not pay for those drugs, they will not maintain the equipment, and we will keep to complain because money circulates and populates whatever is happening in that system. So you've heard there were up to 30 billion bills of the last period, which are yet to be paid, and only a portion of it has been paid. So right now, we have facilities that are very skeptical. They don't trust that you owe me from the last system of NHIF, and now you're telling me, let's continue with another relationship, and I'll pay you, you just trust me, we'll be okay. So there are providers that have become very scared of that relationship, and they're yet to give the best to ourselves as patients. There are others who are somehow favored by the system. They will continue playing in the environment. And they're very few and they're not well distributed. That means access to services becomes limited. So you probably go to Nairobi, very few facilities are providing the services that you want. They're like the full scope. You go to Mashinani, the same experience. So we now challenged, where do we go for care? It's advertised, you can visit facility 1, 2, 3, but because of the last bills not paid, there are issues. Now, as the new bills accrue, well, in the first quarter, October to December of 2024, they have attempted to make payments. And those facilities are somehow running. But as we're continuing, there's still other facilities that are not yet to be paid. And that is affecting service access. So we want the best. for you as doctors, and for all of us as persons in this country. When the systems work, we are all happy. So let's keep engaging, let's keep talking, because it is our taxes. That little contribution is still a tax. When someone will say it's not a tax, it is a tax. Even what you pay in KRA, it's still a tax. Road levy is still a tax. But it's the benefit of ourselves as a people in the country. And we must demand the best as given by the Constitution. Thank you.
Thank you, Dr. Kavura. Martin, you've heard what the previous speakers have said, and there seems to be a laissez-faire attitude in terms of, accountability and oversight, where citizens and people of goodwill are trying to hold the government accountable, but there are pushbacks. So in terms of accountability and oversight, how effective are our institutions, such as the Office of the Auditor General, the Other Office and Anti-Corruption Commission, the Parliamentary Health Committee, overseeing healthcare, financing and service delivery?
Thank you so much. First, I want to say that it is very difficult to speak after Dr. Mtakangwa has spoken for obvious reasons, that he's lived this experience longer and has been part of a lot of the engagement. The question around accountability institutions for health, I want us to start from a simple question. What is our approach to health as a country? Is healthcare a commodity? Is healthcare a commodity like beer that we can flip-flop around with? So how do we approach healthcare, first of all? Or healthcare is a fundamental right for every person. Therefore, it is an obligation of government to provide quality healthcare to all citizens. The approach that we give health would then determine how we engage, including with the question of health financing. Because if we approach it as an entitlement to all of us, irrespective of your means, irrespective of your extraction, it means that even the approaches of financing will factor that in. And we will then eliminate what we call discrimination or exclusion in healthcare. And all the conversations we are having, the challenges they raise is that we have Kenyans who cannot access the healthcare they deserve. If you get the experience of Grace, Grace knew where to go. How many millions of Kenyans do not know even where the SHA offices are, where MOH is? And yet they still deserve healthcare. And then we also need to ask ourselves, where have we been investing in health? And where are we investing in health? Because if we don't ask ourselves these fundamental questions, we then tend to treat health as a commodity, not an entitlement of everyone. Having committed under the SDGs to universal health coverage, if it is universal coverage and reducing the financial burden out of pocket payment that ends up denying people access to healthcare, we then must approach it differently. Enable everyone to access quality healthcare that they need at the closest level possible. And so I get back to the accountability institutions, or the questions that you've asked me. As a lawyer, I am more familiar with legal accountability. All these institutions we have mentioned are creatures of law, and they have legal frameworks that they work under. We want to ask ourselves, it is accountability for who? If that accountability is not going to facilitate access to healthcare for all Kenyans, then that accountability measure is not effective. If we are talking about parliamentary departments, the development of law, Parliament is a critical organ in engaging with all proposed laws. But how come then we ended up with a new legal framework that does not meet the needs of the population? Did our representatives in Parliament, both the Senate and the National Assembly, represent the interest of the citizens? Because this SHA is established by an act of Parliament. And let us not forget that we also still have the Ministry of Health with sizable annual budget for implementation of health programs. And then let us move to, I would not want to speak about the audit institutions because those come after the fact. I want to ask to then look at what have our courts done on the question of access to health for the citizens. When the other systems have failed, with the protection of the right to health under Article 43 of our Constitution and the right to emergency health care, then citizens are left with options including going to court to seek to enforce that obligation of government so that in whatever engagement, in whichever framework the government is rolling out healthcare services, it should then protect the right to health. Professor Mutakangu has already mentioned what the courts have said about the new health system. But we also know that when this was all stopped, at one point the courts again allowed it to continue. Are we seeing a politicization of the judicial decisions when it comes to access to healthcare, especially because money is involved? Are the decisions in the best interest of access to health, or it is a clamor for collected resources and the question of access to pooled funds in this country? Remember, I asked that what is our approach to health? Who is benefiting from the resources we collect in the name of healthcare service delivery? Are we investing in public health facilities? Where is this money going? Who are the largest beneficiaries of the funds we collect in the name of health financing? And if we do not critically look at this, we are beginning to create two classes of citizens. Those who can access healthcare that is funded by the public, and the public that contribute to the financing of health but cannot access quality healthcare. Why? Because the facilities they access are not adequately resourced. And it goes back to what Professor was saying, that what is the ideal model of financing healthcare in the country? What is workable? What is sustainable? If we are collecting to pay largely private institutions because they have invested in health and not with the same measure investing in public health institutions, what are we doing? We are making those public health institutions unattractive, inaccessible. Nobody wants to go to them. Why? Because they have no personnel. they have no equipment, they have no supplies. And then we promote private enterprise. The reason why you invest in the private enterprise is for profit. So when we are promoting private enterprise only, we are saying health is a commodity. It is not a fundamental right. I can't claim to be an expert in health financing, but I dare say any model that does not ground the public health sector as the primary quality healthcare delivery mechanism in this country, and that private health sector is complementing public health sector, that model will not succeed, and it is a foundation of discrimination of citizens, creating the haves and the have-nots, that the haves will get better healthcare funded by the have-nots will not get any healthcare service. And it is a conversation we must have. So when we are talking about accountability, citizens' accountability must be the first place. We, the citizens, must ask ourselves, where is our money going? When you are taxed and government is allocating resources for health, where are those resources going? And citizens organized variously, civil society, pressure groups, and media. And I want to close by giving you a very good example. I have litigated several cases in court, in particular around access to quality maternal health care, addressing the issue of detention, neglect, and abuse in healthcare facilities. And one way that detention happens in healthcare facilities is payment. And this is how payment happens. You are covered under NHIF or SHA, you have sought treatment, the doctor has certified that they are done treating you clinically, you should go home, there is no approval. You are detained in a health facility. You seek health care on the promise that the following services are covered. When you go to hospital, upon treatment, you are now told some services are not covered. For example, critical care that you needed, you are told is excluded. For those in the service healthcare delivery system currently, I know that even what we are calling the benefits package under social health insurance or authority excludes the basic healthcare services that Kenyans need, including women and girls. So who is it serving when you are excluding basic needs that the majority of the population require, or you give them the least allocation that will not meet the requirement or the charges that the hospital will demand? It means when these Kenyans seek care, they are going to be jailed without being tried in those health facilities, detained until when they raise additional funds. My experience with Pumwani Maternity Hospital and Bungoma County Hospital in two separate cases where we challenged the detention of women post-delivery for inability to pay medical fee, the High Court was very progressive. In one, condemning detention for inability to pay fee as being unlawful and constitutional and a violation of the rights of the patient. And this detention extends to detention of bodies of patients who have passed on. It is a fundamental conclusion of law that the body of a deceased person is not property. You cannot detain it for purposes of seeking payment. But this continues to happen. And so in closing, as Dr. Mutakangu said, the devil lies in the details. Even what Kenyans are promised as a working system, if you ask yourself, what is the benefit for the citizen? It is very narrow. And so we must go back as citizens to hold our government accountable. And let us not wait only to go to court, because we therefore see that the political pressure on the courts to let the system continue, irrespective of its weaknesses, is so immense. Let us start addressing the problem from its roots. Let us hold our leaders accountable. Let us highlight the gaps and the challenges. Grace is just an example of the things we can do. If it is not working, let us call it out as not working, because health is not a favor from government. Health is a fundamental right of all citizens. And there is no excuse, no argument should be said that there is less money allocated to the Social Health Authority. No, we pay taxes. If government cannot offer health care, it has no business being in government. It should go home. Thank you.
Thank you very much, Martin, for that wonderful presentation as well. We'll move to our public finance expert, health finance expert, sorry, from the Institute of Public Finance. You recently, I think in 2024, conducted a research publication which you titled Healthier Debate Needed, Drawing Lessons from Past Experiences to Ensure Success of Kenya's Social Healthy Insurance, what you termed as SHE. And you've heard that healthcare is becoming very expensive in Kenya, with people having aspiration that, NHIF and then now transitioning to SHIF will really cover their medical expenses, but that is not happening. From your research, what were the key findings? And also, just drawing from that experience, what are the key financial implications now transitioning from NHIF to SHIF?
Thank you very much. Can you hear me? Sorry, can you hear me now? Okay. Hi, everyone. Okay. So my name is Gladys, as has been mentioned. I'm a health financing researcher. Forgive me if I'm not a very impassioned speaker. I work behind the computer and writing is my main means of communication, so forgive me. Yes, we did do a research study on the social health insurance. I feel like the microphone is not working. Is it? Closer? There. Sorry. Okay. I'll try and project my voice. So we tried, once the different acts came into place in 2023, but during the ceremonies, we tried to map out the different things that the government is trying to achieve with the different reforms that it's proposed and everything. So one of the things we did is looked at other countries that have done this and how they've done it. So social health insurance is not something new. It's not something that Kenya is the first country to do. It's something that different countries have been doing, and there are lessons to draw from that. I think we always say there's nothing new under the sun, and we can learn from other people's experiences, learn from other people's failures and everything. And also, in addition to that, some of the reforms that are happening right now are not entirely new in Kenya. We've tried them before under NHIF in different variations, in different formats. So that is sort of what we tried to collect. And we looked at it in terms of 7 different reform components that we are looking at. And allow me to look at the financing aspect first. So the biggest change that we saw with NHIF to SHIF is the change in the contribution mechanism. So initially we were all contributing a flat rate depending on the income band that you're in. But then now with the new system, we are contributing based on a percentage, 2.75% of our income, sorry. So some of the justifications that were given for this change is that the old system was not progressive enough. So progressivity tends it's the same concept that we use in taxation, where we say that people with a higher ability to pay contribute more. And to some extent, there was truth in that. For example, if you look at a person who earned 20,000 shillings under NHIF, their contribution was about 750 shillings. That's 3.75% of their income. If you look at a person who was earning, say, 100,000 shillings, their contribution was 1750, and that was about 1.75% of their income. So you see the people who are earning less are actually parting with a greater proportion of their income compared to the people who are earning more. So that is one of the things that I was trying to address. But now we've looked at other countries that have done this, and the thing that comes out is that we've not taken the best approach, as Dr. had said. We've not taken the best approach in this. And why do we say this? There's a World Bank study that has been done that has been monitoring 25 countries that have been trying to implement social health insurance. So the study is called Moving Towards UHC. So it tends to be renewed and revised every year. There are additions, lessons learned. And we see that for the 25 countries, none of them have actually attained UHC by relying mainly on contributions from citizens. It simply does not work. So the ideal ratio has tended to be 70% is government financing, 20% is from contributions, 10% is from other sources. And if we look at the Kenyan system, we see that the greatest burden of the new shift system came onto the formal sector. We've said that they are not enough within the country. We have about only 3 million formal sector employees. If you look at the average wages, 88% of them earn less than 100,000. The average formal sector wage right now is 72,000 shillings. So based on that, I am a maths nerd. I am an econometrician. I love numbers. So we tried to assess the different revenue amounts that we can get under the different scenarios. So we tried to simulate different scenarios. So the one that I will reference to is one where we did the assessment. So first of all, we looked at the change in revenue from the formal sector. We used the minimum wage of 72,000 to calculate the expected revenue. So first of all, we see that it will generate an additional 23 billion approximately. This is just estimations. And then if we look at the formal and informal sector, it has already been mentioned before that affiliating the informal sector is one of the most difficult things to do. Different countries have tried it and it's not worked. Philippines has tried, I think, the most approaches to affiliating the informal sector, none of which have worked. The country that has had good significant success is Rwanda, which has had about 87% of its informal sector enrolled and affiliated. But just because you're enrolled does not mean you'll pay. So what we are seeing with the Rwanda system is that, yes, we've covered 87%, but the attrition rates are very high. It's almost running into deficits. So if we look at the revenue under NHIF, formal sector was only contributing about 6 billion. So the informal sector rather, sorry. And this is because only 25% were enrolled. Of the 25%, only 12% were actually keeping up with their payments. NHIF released their regulatory impact statement for 2023. If you go through it, you see that the payouts from the informal sector, the benefits payouts, were more than 100%. That means that it paid more than it actually generated from the informal sector. And the thing that the government, and I quite don't understand yet, is the approach we've decided to take with the informal sector, where we are using the missed-testing approach. I think this is one of those elephants in the room that needs to be talked about because we can't just ignore it. Means testing in Kenya, if you've worked within the social protection programs in Kenya, you know we've done means testing for a very long time. There are very many assessments that have been done on the means testing programs in Kenya, and they've just shown that it simply does not work. We are not good at it at all. So if we look at, for example, we take the Hunger Safety Net program, that one had inclusion errors of 68%. What do I mean by this? It means that 68% of the beneficiaries who are targeted for the subsidies and for all the government benefits did not actually deserve it. Let's go to the health insurance. We've done it before with our health insurance system. We had the health insurance subsidy program. If we look at that one, we had an inclusion error of 65%. And best believe, All of them were in the top 2 quintiles of wealth, meaning we are subsidizing people who are the ones who are most likely to actually afford to pay these premiums. So what exactly are we trying to do? What are we trying to achieve with this system of ours? And it's a bit, I am finding it very difficult to comprehend what we are trying to do and what we are trying to achieve. And I think, while yes, I think even when the government was talking, it kept saying that the informal sector will be the one that will help us consolidate and generate a lot of revenues, but we know the challenges with affiliating the informal sector. We can't have based our hopes on something that we've seen already doesn't work. So it sort of doesn't make sense in that regard. And then if we look at the other issue is, so we've mentioned that the PHC fund and the ECCIF are supposed to be government financed. SHIF is the one that is supposed to be the contributory system. So I hope we've all looked at the PBBs, the program-based budgets. So the first allocations to these funds were done in 24-25 financial year. So primary healthcare was allocated 4.1 billion shillings. ECCIF was allocated 2 billion shillings. Now, beyond looking at what they've started with, I was like, okay, let me see, maybe these numbers are going to increase. Are we projecting increases? Are we not projecting increases? So for the PHC fund, the government for the next 2 financial years, the projection was that the allocations would remain at 4.1 billion. And that is counter, it seems counter to what they're saying that they want to shift towards a primary healthcare system. We should be seeing investments towards PHC increasing, but they're not. Even when you look at the programs in the health sector, we're going to ignore the mess that is there with the programs that we currently have. We have programs like Curative being mixed with RAMCA. That's very confusing. RAMCA is a primary care service. So, but even when you look at the primary care services programs within the government at the national level, the ones that are performing the worst. They had the lowest budget absorption in 24-25. In 23-24, sorry. And so it's sort of counter, there's no alignment and cohesiveness in what the government is trying to do. If we look at the Emergency Critical and Chronic Illnesses Fund, so the allocation was 2 billion shillings. Would you believe me when I said that the projections for the next 2 financial years were a quarter of that, 500 million shillings? So we are saying that we want people to access services through government financing, but we are not allocating funds for that. So how is that actually going to happen? And I think that's when we have statements. I think recently we all heard, they say that we did not allocate enough to SHA, and it's a bit crazy. But also, in terms of the financing, I think there's something else I always like to talk about. We always say we don't have enough money for health. And I agree. Actually, our allocations to the health sector, in real terms, when adjusted for inflation, have been declining. We've not met any benchmarks for UHC, nothing. And we are not seeming to make any progress. For example, if you look at health as a share of GDP, it's declined to 1.4%. We're supposed to be at 5%. If you say we want to achieve UHC, there are simulations that have been done on the levels of investments you need to make to achieve it. Currently, it's estimated you need to be spending per person $86 US. We are spending $32 per person on health. If we look at health expenditures as a share of government expenditures, decades ago, we all committed to a Abuja declaration. 15% is going to health. Hatujaifika hapo. We do not even seem to be moving towards that direction. And we can already see the impacts of this. If you look, the National Health Accounts provides the numbers and the statistics for all sources of financing within a healthcare system. If you look at Kenya's, the trend in out-of-pocket expenditures is actually going up. 25%, currently 25% of the total health expenditures in Kenya is out of pocket. What does that mean? It's the big issue that we all talk about in health system, catastrophic health expenditures. Meaning that everybody is sort of one medical bill away from poverty. So it will either cause you to move into poverty or to move further into poverty, which is what we call impoverishment. So it's been a bit of, there's a lot of confusion. I think I hope I'm making it clear that I am very confused at what the government is trying to do. The lack of cohesiveness is very insane. And the other thing I wanted to talk about, there's an issue we constantly say of transparency and accountability in healthcare systems. Occupy MOH was one of my proudest moments as a Gen Z. Yes, we occupied the streets, but for me, MOH is personal. It is personal. In 2023, when we were starting, in 2024, when we were starting to work on this paper, month 2 of working of the paper, I got seriously ill. I got admitted outside Nairobi Hospital, outside Nairobi County. So I was admitted there for 1 day, and I had to be moved by ambulance from there to Nairobi because there is no pulmonologist. I have a respiratory health issue. That's why I sit at doors, near doors. So I had to be moved more than 2 hours by an ambulance to Nairobi to get care. Now, leave that alone. Oh my goodness. Since I was admitted for 1 day in the other place I was at, my medical bill came to about 48,000 for 1 night. When I was being discharged, there's that NHIF message that comes in telling you how much NHIF has covered for you. I looked at it, I was like, is this meant to be a joke? It covered 3,000 shillings. Covered 3,000 shillings. When I came to Nairobi, I had to be put on medical oxygen and a couple of other medications. So my bill for about 3 or 4 days came to 280-something thousand. NHIF covered for me 13,000 shillings. And I thought, what am I supposed to do about the rest of the amount of money? I have been contributing. You're asking for more contributions from me now, and I'm not getting coverage as I should. And I think that was one of those moments I just thought, we've got to do something and make this thing work. Otherwise, I think there are many more people out there who can't actually access these services. I always say there are people behind the numbers. Let's always remember that. In everything that we do, there are people behind the numbers. The reason why we are trying to make the numbers work is because there are actual people who depend on it, desperately depend on it. The last issue I will touch on is on oversight by Parliament. I'm sorry to use Gen Z lingo here, I have beef with Parliament and oversight. I think they do not do enough. They do have the powers, but they do not do enough. And the good thing is I have evidence to support my claims. So every year, every 2-3 years, there's a survey that is done that is called the Open Budget Survey. So it tries to assess how different governments are doing in terms of transparency, accountability, oversight. If you look at our audits, we tend to score very well. We are scored out of 100 for every point. So we score 72 out of 100. So that is above average. But he had mentioned the fact that audit comes after the fact. So there's nothing we can do. Even now, if you look at the NHIF audit reports that are being discussed in Parliament, they are dated reports. What are we going to do about that now? But then if you look at the parliamentary oversight during the course of implementation of the budget, we score 52. That is below average. Meaning that as we are executing, as the financial year goes on, there's no sort of accountability that we have for these institutions from Parliament. And don't get me started on the opacity that NHIF had. Their documents were rarely ever available. I think we could only find one audit report when we were doing this study. The others are not available. And I'm worried about whether SHA is going to do the same thing, the board. And I think there was one thing, I'm not sure if I'm the only one who's pained by the fact that the SHA Transition Authority never gave us any reports. The Act said that they were supposed to develop a report, but then now they introduce this lingo where they can release what they deem to be irrelevant. What do you mean what you deem to be relevant? These are national assets. They're not supposed to be private. They're not supposed to be hidden. Everything should be relevant. We should be able to see what is happening behind the curtains. Because otherwise what you're going to end up having is a situation where we come back later and say, oh, we lost, I don't know what percentage of our revenue because of claims that were fraudulent. We have no system of accountability and no way of ensuring accountability of the systems. So if I were to be asked, I'm sorry, I'm taking the moderator's role. If I were to be asked, first of all, I need government to be coherent in what it's trying to say and do. Let their words be matched by actions. Number two, I think Parliament needs to do more in oversight, the health committee especially. I think it's good for them to start inquiries as often as possible. The other thing, I think we need SHA to be very transparent from the onset. If there's something I am waiting for, it's the first year financial report of SHA. I am waiting for that report with bated breath. And if I have to go to SHA to get it, because at some point those were the only measures we could take to get some reports, trust me, I will do it. Because I think there's a lot that we need to see and understand the decision making, the rationale that is behind some of these decisions. And with that, I think I'm done. Thank you.
Wow. Thank you so much. Hello. So let me say that we will work with you, in this room, to go and find that information. But I think if you look at chapter 5, it is very clear that that information is all right. We need to have it. I've listened at the laws, the mathematics, the resources, the voices, the lived experiences. Something is terribly wrong. And so, listening to Awala could give us the opportunity of saying, so what are the communities saying out there? What is our role? We were here and they said, how angry are we going to get? We need to get angry to be able to work all of us together and say that whatever is wrong must be made right. And it can only be made right when the voices and everybody else is speaking the same language, that all of us must be accountable. I agree. Budgets and issues of what is come later, but we have institutions that are supposed to take over those recommendations. What happens? The law is supposed to help us progress, but also deter bad culture and bad behavior. We need someone to capture the bad behavior. Thank you.
Thank you very much. And speaking last after experts have spoken, quite a challenge. But as a community practitioner, when you are in these communities and you mention SHA or SHIF, the first thing that comes to their mind is NHIF. And the second question is, hiyo ni nini? What is SHA? What is SHIF? Ni nini hiyo? They do not understand. And that points at one thing that didn't happen with SHA, creating awareness and public participation, which the courts mentioned. Even though it was done, and we know how our parliamentarians do public participation, notice come to civil society organizations that are government friendly, and you are given less than 2 days to prepare and then make an appearance at the parliamentary committee. Barely you will say nothing, because there's a new law that you don't even understand in the first place and what it's supposed to mean to communities. That is one area that has really done the communities a blow. Now, if I'm to pick from lessons of UHC pilot, those people who engaged or interacted with the pilot phase of UHC, I had hoped that as government they'll pick lessons that were there. One, the pilot phase actually did not eliminate out-of-pocket payment completely. At the point of entry, that is what it did, but at the wards, you were being sent out to go and buy things for you to be attended to. What is happening currently with, or used to happen with Linda Mama, tutakutibu bure, but go and buy ABCD. That was also a gap. Another gap was on human resource for health. There was an influx of patients, but then there were less health professionals to attend to them. Now, these things angers communities when they go there. They'll tell you, I remember when we used to work and we still are closely with KMPDU, I used to tell them, come to communities. People are angry with doctors. Anybody in a white coat, whether a doctor or not, to them is a doctor. And when they are asked questions at the facilities, they shy away and go. And that is how they go to private facilities when they are holders of NHIF of SHA. Another thing with private healthcare provision was that I don't know how hospital empanelments are done, but even in ghettos, in very poor low-income areas, you will see a facility written NHIF accepted, a Mabati somewhere. You're not even sure whether the person you're seeing inside there is a doctor in the first place, or whether you'll get quality healthcare services provided for. But somehow NHIF was reimbursing these kind of facilities. So this is what Wakili mentioned here. A lot of public funds are moving into private hands. I don't want to mention some facilities, but you can all see it's all out there. There are facilities that just mushroomed from a one-bedroom house to a flat. And that begs the question, how many poor people are they seeing using public insurance card? Because during our research on NHIF then, we realized 65% of NHIF money was actually flowing to just 3 facilities, private facilities, big hospitals, which are not seeing any poor person. So it means poor people are paying for people who are able to pay for their health insurance. Now, this as an activist have usually angered me, and I've always been asking myself, how do we make communities angry? Because when votes are stolen, everybody comes out. Everybody. Even the person who don't know how they were counted comes out. But when there's news that money has been lost at KEMSA, they don't know the impact of that on them in terms of access to healthcare. When PPPs are done, like the big mess, you remember it, where government goes into contract with private companies, and then money is siphoned out of Kenya into those. They don't even know how that impacts them. And we know up to now there are facilities that have those equipment and have never used them, and they don't even have expertise to operate them. These are the gaps we have, and these are the things that denies community people to access quality healthcare. Another thing I wanted to mention was, even with the Rwanda case, we can use the Mijikumi like Kagame did. They borrowed the Mijikumi idea in Kenya, and we have all the data. We have the Huduma number data. We have all the data. Government knows everyone. Then use the data to publicly pay for those in poor households, and then charge those who are in employment and those who are able to pay. They spy on our M-Pesas. They know everything. Then we have moved more people into the scheme, so that now we start the debate when they are there. Because even those who are in chief now are people who have been transitioned from NHIF. Why is there low uptake from communities? That is a question that should be asked. So as Wakili said, we just need to go back to communities, make them angry, and make them demand for healthcare service delivery as my sister did. Thank you.
Thank you, Dan, for the presentation. Now, I don't want this to be a one-sided discussion because we brought different players in this room. So I will allow the panelists like 2 minutes each to give us their final reflections. If you have any recommendation that you can also give us, we'd really appreciate. And then from there, we will move to plenary, where we'll allow the participants to interact also with the panelists, because we do not have all the questions. I know you have very many questions that you want to ask. So 2 minutes each as you give your final reflections. We start with you, Grace.
I would like to say that it is your right to get treatment, especially for emergency. I had started a channel talking about patients' rights. It is your right to know where you're sick, what treatment you're getting, and it is your right to say no. It is not a must to receive that treatment that the doctor is giving you if you're not comfortable. It is also your right to go and seek a second opinion. So the minute you're told, I'm operating on you, I need to do this, I need to do that, if you're not comfortable, or even if the doctor who is examining you, if you're not comfortable, it is your right to say no. The second thing I want to say is thank you very much for everybody who supported me. And whenever we see something going wrong, let's stand up for each other and let us stand with what we believe in. Let us not compromise, because everybody has something that they were born to do or something that they believe in. So take it as your gift or whatever you believe in or whatever you're good at. And also, I would like to finally say that I am starting something that it's gracenjokimole@gmail. I'm asking for the people who need help or advice, they to reach me out to me. I may not be able to help you financially, but I'm free to give advice, and I'm able to find a way of, even if it is comfort, empathy, but we are working on something that will be able to help people know their rights and also know where to go to. Because there are many services here you can get, and some of them are free, and there are some Kenyans who are willing to help. So thank you very much.
Well, thank you. Mine is to echo what happened last year, June 2025, 2024. Remember the Gen Z movement, Occupy Parliament? It was an awakening call. And the fact that we've been speaking about healthcare, we cannot stop talking about it. And it's unfortunate that the Parliament publishes most of the laws in English and probably technical language that most of us may not understand. Let's say like the way the Digital Health Bill was done, or even the Social Health Insurance Act. It's too technical that most of us may not probably understand it when it's being made as a law. And we need to have a parliament push out popular versions that have simpler English, easy in Kiswahili for us to understand as a people. Because that way we are able to go together. Otherwise, when you're left behind, we now have a situation that is happening today. We are doing post-enactment public participation. So what you're doing is still like further public participation after the law has been made. So we feel left out and we don't feel like we participated to improve the law to work in our favor. So for persons who have connections to parliament, things must be done with the people, not just the 300 persons who are there. We must move together. The other thing is to have, to win trust for the people, we need to have the benefits improved at SHA. To win trust for the providers and doctors, that relationship has been broken by the NHIF, and as we're transitioning now to the SHA, it needs to be restored so that we can still continue to enjoy the services that we are paying for. It's not free. We are all paying for it in many ways. We pay with life sometimes, and I don't know for how long we'll keep on doing that way. So we must wake up and do something for the next day. The other thing is, you've all heard, for the parents, you have parent teachers associations. And the schools meet with the parents and their students. And you talk about how your student is performing and the school is doing and what should happen. Well, in one of the forums like this, some of the patients or the attendants, they did talk that the doctors, the facilities, the insurances, the payers, the SHA, they don't meet the people that they are serving.
Yeah.
And they're not regular meetings. So that you'll always complain that healthcare is too expensive, I was billed this much, I don't know why. And no one cares, and life moves on every day. So if there was to be a situation maybe one day in the future whereby the hospitals, the public and the private, and even the individual doctors, once in a while, they meet with their stakeholders, their patients. And they have a forum where they can talk about the payment, the diagnosis, the cost of care, and everything, even from the receptionist, maybe who's being very rude. Because care begins at that point you get in. Because when someone is so rude to you and you feel like from that point, nothing gets in. The doctor, you not understand the doctor. You not understand the bill. You not understand NHIF. You not understand Jubilee Insurance. So it becomes very technical for you to move forward, and that becomes not a healthy way to operate in that kind of a sensitive ecosystem. So the other thing, the last one, is to consider what we have been talking about, rework the funding model. 2.75% is too extreme and high without a cap for some of us. But anyway, they say they'll bring the cap as the days go by. The reason why I was told that the cap is not coming is because we are few in the formally employed sector. And the informal people in the sector, they're not paying as well. So to continue going for some time, don't put caps. Let everyone contribute until the point where you have some threshold to make it sustainable. But even as we're going on, the persons in the informal sector, when they're signing up, they only pay for those first few months. After that, they get tired contributing. And if that getting tired is happening all the time, the system will not roll for long. So something must be done to promote sustainability. Thank you.
Thank you so much. I want to say a few things as I finish picking from what the colleagues have said. I want to add on what the lady economist said, that you need to know that the Ministry of Health and SHA had costed primary health care at about 67 billion, but our members of parliament, in their wisdom, they thought they should allocate 4.1. Those were statistics that we were given by the ministry. They had costed the emergency and chronic and critical illnesses fund at about, I think, 107 billion, but they were allocated only 2 billion. So as we talk about accountability, when the budget is being done, the people ought to really face the members of parliament, particularly the members of the National Assembly. That if you really care about your voters who access health services in level 1, level 2, 3, and 4, then you must allocate adequate money to the primary health care fund and also to the emergency, chronic, and critical illnesses fund. Now, the second issue I wanted to mention is, which again has been mentioned about, the role of parliament in as far as accountability is concerned. I am sure all of you must have been surprised to watch our members of parliament appearing surprised about the contents of the SHA law. And yet they are the ones who passed it. We have a very serious problem with that institution, because you can't be the ones who are supposed to scrutinize the bills and pass them into laws, and when they have become laws, you get surprised that the laws are saying what they indeed are saying you passed. So we need to address that issue. It's a serious matter. Now, finally, if Odhiambo can allow me, I want to scribble a few things on the flip chart to help us understand where we are missing on health in terms of what the health workers call the pillars of health. When I came into health 4 years ago at the Council of Governors, I started reading in literature, and I find those pillars are thrown in there in the literature without organization. But from a lawyer's perspective, I decided, can I organize them? Perhaps then we will be able to know how they are interlinked, interconnected, how they must rely on each other. And so we invest in understanding all of them. Maybe you can just put it even here and I'll be able to do. So in my organization, I said at the top, we have the pillar on health quality service delivery. That is the top. It is the goal we are aiming at. Then next to this are a number of other pillars which facilitate the delivery of health, the quality health services. Here you have human resources for health, HRH. You need human resources to facilitate quality health services. Then you have health products and technologies, drugs and other supplies. They facilitate quality health service delivery. Then you have health infrastructure. Health infrastructure. Then you have health information systems. Then you have health research. All these are pillars or so-called building blocks of health. All of them are necessary in facilitating health quality service delivery. But these ones must also be facilitated. So below these, you have number 3, which I call health financing. A very important facilitative pillar. It facilitates all the pillars here so that these ones may be able to facilitate quality service delivery. So finance is critical in everything. But below this, we have what we call number 4 is health governance and leadership. Decisions on whether we should prioritize HRH or prioritize financing HRH or HPTs or infrastructure and all that are made within a governance framework and by certain leadership structures. Now, my complaint with health has been when we adopted devolution, the health workers went into self-denial and declared devolution an enemy. Said it has come to destroy health. Are we together? And refused to invest in understanding the new governance framework within which they are supposed to deliver health. They failed, they refused to invest in that. Asking questions, so how are functions shared in this new system? Where are most of the health functions falling? And in this distribution of functions, who is the major employer of health workers? How is money shared in this new governance framework? And if the counties are now the major employers of health workers, do they get adequate money in the division of revenue? Or are we ending up with a lot of money remaining in the national government when the workers have gone to the county governments? These are questions we need to address ourselves. When the division of revenue is being done, most of the times health workers will be on the side of the national government. And then we end up with a lot of money in MOH. Then when that has ended, they come to the counties telling them, employ more workers, promote those who have qualified to promote, and yet they have been given less money. If we understood the governance framework, we would know when to form which strategic partnerships with which level of government at which stage. If it is division of revenue, you push, give counties more money. When the money has come, now you can go to the counties and tell them, now we have helped you to bring more money. Can you do A, B, C, D? You need to understand, the health workers started by saying, how can we be supervised by MCS? In the new governance framework, they are the ones who must pass a budget at the county level, isn't it? And allocate money to health. So you must learn how to influence them. You must learn how to help them to understand the uniqueness of health and why health needs more money. Now, I normally then say, having done this, you may think I started with this. But then if you draw a pyramid, where is the foundation? Yes. The foundation is governance and leadership. Then you come to health financing. Then you come to those others, and the pinnacle of the pyramid is the objective. The poverty of this country is not in the finances and other resources. The poverty of this country is here. It is not in a deficit in the natural resources, in the finances. The poverty of this country is in the deficit of the integrity of our leaders. That is where we need to focus. The leadership we have. This country has enough money to finance health. How many of you read the news from the cabinet in Kakamega? It was circulating. They had a document on the decisions that were made in Kakamega. And some of those decisions included abolishing certain parastotals, matching some. And I can tell you, this is a subject I've spoken about for the past 10 years. I kept saying, we adopted a new governance system, which required us to deconstruct the old structures and construct the new ones. But we chose to patch the new structures on top of the existing structures. The end result has been duplication of responsibilities and of expenditures. That's why we don't have money. I kept saying, health is devolved, water is devolved, agriculture is devolved. Why do we keep regional development authorities? Nobody will listen. If you read the cabinet decisions from Kakamega, they eventually have now said some of those parastotals must go. In 2013, Uhuru Kenyatta appointed a task force chaired by Abdikadir for parastatal reforms. That task force sat, gave a report which said a number of those parastotals must be abolished, some must be merged. Nobody wanted to implement that report. That cabinet decision now, because they see there is no money, they finally now have said, we must implement, and some of them are going. And if you read that report and you see even the names of some of the parastotals duplicating each other, you will be shocked. And we have been allocating money to them. We have enough money, which we have refused to organize how we should use it, how we should use. So going forward, we focus on that. When the budget is coming, now Trump has said no support from America. We should be asking ourselves, this thing we have put in Parliament called Women Fund, why don't we just put it in health? It is women who are suffering these health issues, isn't it? Why don't we just move it to health? Youth fund, whatever. If we said now Trump has said this, can we reorganize our budget? We have money to do that. Finally, if we focus on this, One of the things, and recently, towards the end of last year, we had a meeting in Naivasha with governors, high level, even with the Minister for Finance there. And one of the papers I was presenting was on the financial implications of national government policies and legislations. And I went through and I said, across the world, literature shows that implementation of policies and laws fails when we do not audit those policies and legislation at the making stage for financial implications and provide for a budget for them. And I asked the question, does our constitution envisage that problem? And I said, yes, we have a provision in our constitution called money bills. The concept of money bills in our constitution, which can be an accountability mechanism for parliamentarians when they are passing these laws, is to look at the bill. The speaker is supposed to look at it and ask himself, is it a money bill? If it is a money bill, the constitution says it must be dealt with in a special manner, which includes it being given to the Minister for Finance to audit it for financial implications. We also includes it being given to the Appropriations Committee to audit it. And I told the members, the 4 laws in health, were they treated in Parliament as money bills? The policies, and I started with the Kenya Kwanza policy, the manifesto, which promised so many reforms in health. And when it came to financial implications, that policy said, these reforms will be budget neutral. Young lady, budget neutral means it will not require more money, isn't it? Did they tell us the truth or did they lie? Then from that Kenya Kwanza manifesto, we come to the laws. When they started and they were in a hurry to pass them, the health, social health, and the digital act bills started in the National Assembly. The memorandum disclosed their money bills. But when it came to considering them, they were not considered as money bills because the standing orders of the National Assembly have draw a distinction between government bills and private members' bills. And those standing orders, unconstitutionally, in my view, say that the speaker can exclude government bills from going through the process of money bills. So they were not treated as money bills. The primary health care and the facility improvement financing commenced in the Senate. And because they have always thought money bills means a money bill cannot originate in the Senate, and this time they were in a hurry to get these things passed, so they said these other two should originate in the Senate. The memorandum said they are not money bills. And then when you go into the financial implications for citizens, huge. People in salaried employment moving from contributing 20,000 per year to now about 300 and something a year. And you go to the hospital, some of the things are not covered, and you are left. Going forward, I told these people, can we then ask ourselves, with the devolution, should money bills only be sent to the Minister for Finance at the national level, or should they also be sent to the counties? Because many of these national government policies and legislations create additional financial obligations for counties without providing the additional money. Thank you.
Thank you. In closing, I want to assume, Prof, you may have taken 1 minute from each of us. So we'll help in redeeming the participation time. But one, I just want to note that we, as a country, we cannot afford to create different standards for access to healthcare for different counties. Let us not invest in creating inequality. Let us invest in creating standards that apply to citizens across the country when it comes to fundamental rights and freedoms, including health. One of the things that we did not consider, and Parliament has not been challenged, in 2017, Parliament passed the Health Act. In all these conversations, there is no harmonization of the Health Act and structures created therein to ensure standards across the country with all these new developments. I think as a country, for once, we need to be a bit serious because health affects all of us. Secondly, the next, in concluding, is that as a public, it is not somebody else's problem. It is all our problems. Let us engage on health accountability. All of us, do not leave it for it is for so and so. And for CSOs, this is the point to engage communities to clearly know where is the problem so that communities can effectively engage. The media plays a big role in amplifying community voices and cries. Please let us spotlight the health challenge in the country more. You may not know the impact of highlighting the gaps, the failures, and the challenges of citizens in accessing healthcare. But it means a lot to amplify the voices of citizens, but also to put the duty bearers to account, including when they now decide to oppress citizens from questioning their inaction or misdeeds. Finally, let us not forget that the Constitution has created available institutions to complement citizen accountability. Let us not tire from going to court, and when they give us decisions we don't agree with, let us critique them publicly so that they know that they are part of the architecture to help us hold the executive and parliament to account. Thank you.
Thank you very much. My rallying call at this point would be to us within the room and by extension to citizens. So we've said a lot about government and what government should and should not do. But I also want us to become very familiar with the budget processes in Kenya. And I want us to become very proactive in interrogating the different budget documents that are there. Most of these decisions tend to be reflected. You'll get hints of some of these reforms and some of these changes happening within the budget. And I say this because we've seen, for example, we have HRH issues, HPTs, health infrastructures. Those will not be directly touched on in the insurance system, but then we'll have government allocating funds for that. And it doesn't matter how good our insurance system is if we don't have health workers to provide the services to us, if we don't have hospitals to access the services from. So I'd like for us to really try and interrogate the budget documents. And sorry, let me just mention one thing. I think particularly this financial year's budget will be very interesting to interrogate. So the 2025 BPS has just come out, and this is where they refer to shift as the seismic shift in Kenya's healthcare system. And one of the interesting things that has happened is that there's a very big increase in allocations to the health sector anticipated for the financial year 2025-26. But then if you look at where that change is happening, it's in general administration. The budget is projected to increase by more than 5 times for general admin. So this is just me giving you hints of the areas to look at once the program-based budget is out. Those are some of the areas where we tend to find very weird things happening, this international travel, domestic travel issues coming up. So one, I would say we interrogate the budget documents very, very well. And number two, I ask for collaboration. So we've always been criticized for working in silos as CSOs, Yet, I think there's a lot of power in voices, in cumulative voices, where your work feeds into my work feeds into your work, you leverage on mine, I leverage on yours. We all have very different strengths. We all have different things that we bring to the table. Imagine if we actually brought together all those strengths and used them as one solid, constant voice for the people. I think we're able to bring a lot of change that way. And the last thing would be, I am very biased. We've done quite a lot of research on health in the Institute of Public Finance. We've done a lot of budget analytics, actually. And then in addition to that, we have this new paper in Chief. I ask us to actually read these papers. If I do say so myself, they're quite nice. So I think we can try and see how we can use some of the findings in this research to inform the works that we are doing, and how we are also able to advance some of these issues that we are raising in the different reports. And with that, that's it from me. Thank you.
After Prof has took us to the lecture room, I think everything is now clear. But one thing that Chief Act really missed on was defining what emergency care was. And this is a big gap for citizens. She shared her experience in an ambulance. So ambulance service should be part of emergency care, if you ask me. And that is what actually fails many people from community level. Number two, I just wanted to ask, Prof, is there a way we can increase the money the national government remains with, under the Ministry of Health remains with the 65%? Can we devolve more, because more functions are with counties? So what are they doing with 65% of health allocation at national level, yet services are at the devolved level? Another thing I would really discourage now that Trump has happened is over-reliance of donor to fund our programs, like HIV programs, and so many programs that are now going to be impacted on. And I think MOH does this deliberately to counties, because they know donors will go there and they will cover those programs. Another thing I would want to mention is the biggest problem we had with NHIF was its inability to interrogate bills that comes to it. Will SHA, now that we have SHA, will SHA have this capacity? Because that is where a lot of money shifts from public into private hands. And lastly, I would want to say, even this SHA shift discourses within urban centers. What's happening in rural areas where the majority of Kenyans are? What's happening there? And lastly, insurance-based model, Prof, in my opinion, is not the best way to achieve UHC. It will expand space for private players and come to what Wakili was saying, commodify, commercialize, and marketize healthcare. Thank you.
Thank you very much to our esteemed panel. I think it is very clear. And so right now, I want to open the floor so that we can engage with the panelists. If you have any questions, if you have any comment, perhaps you need clarity on something, this is your opportunity. So I will ask my colleagues at the back to assist me with revolving the mic in the room so that anyone who has something to say can have the opportunity. So I can see a few hands, so we can start with the...
Good afternoon. I'm Christine. I'm a CHP. from Mathare Ghetto. I have a question. Why should government, in my opinion, ask someone to first register SHA to get treated at a hospital when someone like me who has a condition, I'm asthmatic, needs immediate attention? Should I go first register? See, I will die. Secondly, are people are asking back in our community? They did get a direct message from NHIF, umehamishwa from NHIF to SHA. They are asking, why are we registering again? That's all.
Assalamu alaikum. Mimi ni Hamisi Saidi, chairman CHP's Mathare Sub County. Pongezi kwa ICJ na nyinyi wenzetu hapo. Kwangu mimi ni kukuuliza Bwana Dan na panelist wote mko hapo. Ni lini utakuja kutukasirisha Mathare? Ili ndio tuwe na ukweli na kujua Chief SHA ni nani, alitoka wapi, amekuja lini na yuko vipi. Sababu ukweli hamasisho aliko. Na ningeomba profesa yuko wapi? Profesa, PHM wakija Mathare, sisi ni grassroots, watu wao kule, mobilizers. Ningeomba nyote mje kule ili msaidiane nao, tukiwa na sisi kama mobilizers, tuhamasishe wale wenzetu kule kuhusu haya maneno. Sababu wengi kusema ukweli wanaumia na magonjwa. Hali ya mitaa yetu ya mabanda si mnaijua? Watu wanaumia sana na magonjwa. So wanadani PHM na stakeholders wote mnakaribishwa Mathare nyote. Njooni tuwe kama na crusade moja ya kuhamasisha wale wenzetu. Asanteni.
Asante. I have only two issues. One goes to the professor, the issue of governance. Jina langu ni Charles. The question I have is the concern that has been there, the back and forth of on concerning the management of health and medical issues. According to you as an expert, which structure do you think is better placed to manage medical and health issues better? Is it the national government or the county government? To my second concern, issue of CHP, community health promoters. One time I managed to interact with one of them, and I realized that the work they do is a lot. The workload is just too much. It is time we tell the government that this is not voluntary work. Because if one CHP can handle around 100 households, something even the doctors cannot manage. These people are beyond being volunteers. They need to be allocated good salary, benefits, allowance, pamodium. Hizo zote. Sindio? Do you agree? Yes. CHP is in the house. Muko up? Yes, I think maybe, Professor, you can also advise us on that. Have you at even some point thought about that? And now, because you are very close to the council, yeah, the council of governors, you need to tell them bana hawa watu tuwaweke pesa mzuri, ndio wafanye kazi mzuri. Tafadhali. Thank you.
Assalamu alaikum. Once again ni Salma Wambui Twalib kutoka Dagoretti North, Community Health Promoter. Professor, uliongelea kuhusu gadget. Ukasema hizi gadget zetu za CHP zikuwe kwa system ya level 1, 2, 3 and 4. Well, hii gadget yenye mimi nimepewa haiwezi kuniaccommodate huku kwa kijiji. Itakuwa updated aje kwa level 1, 2 and 3. As we speak, mimi natumia hii simu yangu. I was able to submit my report of last month. Wenye ambao walikuwa na zile simu tulikuwa tumepewa, hawakuwa able kusync. So hata hizo gadget mnaongelelea ni zile za Safaricom zenye vision yao ni ile ya zamani. Tutakuwa updated aje? 2, tunaambiwa tu register SHA. Mimi mwenyewe SHA sielewi kama nyumba yangu nitaenda kuregister household 100 aje. I was given a training of 1 day. Hiyo 1 day it is not enough for community health promoter kuingia kwa nyumba kwenda kuregister. Sielewi. Self assessment inakuliza kuku, inakuliza pesa. Hizo zote unaenda kuexplainia aje household yako. Ile pesa ambayo inasemekana tulikuwa tunalipa 500 kwa ile ya chini kabisa NHIF. Tukaambiwa inaenda 300. Unaambiwa ulipe 8,000, 9,000, hiyo yote. Mimi sielewi. I was supposed mimi nilipe kwa mwezi 100 ngapi? 3. So hizo ni vitu tunajiuliza kama community health promoter. Tulikuwa na oversight. Bwana Sifuna alitukalisha chini tukamwelezea hizi zote. Bill ishakuwa passed kwa parliament. Inaenda kwa senate. Wanaenda kuifanya aje? Because hata hiyo document inasema community health worker, not a promoter. Not a promoter. I'm not a worker. Just a promoter. Tunaenda kukatwa. Hao nyingine wamekuwa for 20 years, 30 years wamekuwa wakifanya hizi kazi. Wanaenda wapi? Just because level of education haiko sawa sawa. So kuna vitu hata si community health promoters tunaumia, but we don't have anyone mwenye tunaenda kumlilia. Ukiongea Chando hapo. Ukiongea kuna sub county supervisor ako hapo, unaongelelea wapi? So hizo ni vitu tunafaa tuziongelelee. Pesa tuliambiwa ni 300. It is more than 300. Surely Kenyans unalipa tax. Natoa hiyo wapi pesa tena kulipa hiyo pesa mingi? Asante.
Okay, good afternoon. My name is Frederick Odhiambo. I work with Haki Jamii. I have 3 questions. One, to Prof. If you look at NHIF, the people who are registered in NHIF were 19.1%. So when we are transitioning to SHIF, I don't know if you also question that, because how are we planning to bring in the 80% of the people who are using out of pocket into SHIF? Number 2, to Kahura, the major problem we have in this country is human resource. World Health Organization recommends that we have 1 doctor per 1,000 patients and 25 nurses to 10,000 patients. But in Kenya, we are really struggling with 1 doctor to 5,000, almost 6,000 patients, and almost 42 for 1 nurse to 42,000 patients. As a union, because every day we are fond of having doctor strike, and even like we can't go like 6 months without a notice of doctors or medical practitioner strike. Is there a way that the shift thing addresses the issue? And if, as a union, if you have been able to interrogate the same. My last thing is, the last question come as a public health practitioner. When you look at the health facility fund, there's currently the county government system, the county government is trying as much as possible to get resources. And from public health angle, there is amount normally collected, especially if you go for health license, if you go for medical, mostly those who are in the hotel industry. Is that money part of health facility fund? is it supposed to be because that money goes to the county treasury? Are we supposed to bring that money back to the facility? Because if you look at almost like most counties have taken public health sector out of the hospital, it's more of resource mobilization department. Thank you.
Perhaps I will request that before we go to the next people want to ask questions, we allow the panelists to respond, and then we'll have a final round of question, and then we'll close it.
Okay, thank you so much. A number of questions. The first question was about why you should be asked to register before you get services, and perhaps you are asthmatic and you are in dire need. I want to think that if we understood the concept of emergency services, which are supposed to be free and without delay, definitely we should be able to manage the issues of registration, bearing in mind that we shouldn't delay someone who needs to be on treatment because we are still registering. So it's a serious matter, and it's something we need to think through both administratively and in the financing arrangements we talked about. Now, I need to add, number two, that when we raised issues about why citizens should be asked to pay for under social health for them to access the primary health care fund and the emergency fund, we were misled. The SHA and the ministry told us, no, these two funds, all you need is registration. But the challenge we are facing, which we need to address and raise with them, is that they have linked the registration to the proxy means testing. So there's no way you can be registered and be able to access the primary health care services without first being registered under the social health insurance. So they go for the proxy means testing, then they give you a bill, and you are told you can't complete the registration until you pay the money. Now, I think before last week when the Trump issues came up, some of us at the Council of Governors working with some of the USAID implementing partners, we were working on a document to identify all the challenges that need to be urgently fixed, and seek to convene a high-level consultative meeting with the SHA and the ministry so that we insist that some of those things are addressed. If you are saying people should access the emergency fund and the primary health care fund, even if they are not if they are not paid up under SHA, then you can't link their registration for those two funds to the proxy means testing. So they need to see whether to delink or not, and we see what happens. Now, the question of sensitization, I agree with you. There is a lot that needs to be done, not just in Mathare, but across the country. And as I said, it is not just for the citizens. Even the members of parliament who passed the law seem not to understand what the consequences of this law are. They may not have looked at the tariffs that were developed by the ministry and SHA. They may need to look at that to see how these things seriously impact their citizens and so on. So we need sensitization. Now, the governance, should health be a national or a county function? I wanted to say that and confess that this thing of devolution was my baby, and I fought for it very hard. I am yet to be convinced that I was wrong. Actually, I think that ever since we got independence, or ever since the colonial days, the first step as a country we have ever taken, a practical step to question the political economy of the past, which was founded by the colonialists and was based on marginalization was the adoption of devolution. Unfortunately, those who were benefiting from the centralized system of government came to understand that this is the biggest threat to our vested interests in the old system. And ever since we started implementing devolution, they have been working very hard to portray devolution as a failure. And health was used, that's how they even misled the health workers to fail to understand what I was talking about there, to fail to invest in understanding the system, because they knew that this devolved system is going to reduce our control over the public financial power of the state, the public finances. The real power of the state lies in the control of public finances. And in a country such as ours, the state is the largest business entity that controls a very huge spending power. And in a centralized system, this spending power was controlled by just a few individuals in Nairobi here. And you know now the corruption has gone into procurement. And that brings me to the issue of the gadgets you're talking about. Have you asked why, even after devolving health, people insist on procuring things for county governments? People insisted on keeping a centralized KEMSA because they don't want to lose control over that spending power, because corruption has gone into procurement and they use it. And in this country, we end up with very many overpriced things, some of which do not even meet the specifications. And perhaps that may explain the kind of gadgets that you may have been given. So I will tell you that I don't think that we should continue with the health at the national level. If we actually implemented the constitution well, and one of our biggest problem is that we are trying to implement devolution, but devolution was housed in a constitution that provided for many other things which we have refused to implement. One of them being leadership and integrity. And the criminal law function is a national government function, and the national government has refused to implement the criminal law on leadership and integrity. And I can tell you, I can't even defend counties, because on corruption, there is corruption at the national level, there is corruption in the county level. But if we enforced that, if we enforced leadership and integrity, you will see a lot of differences. If you spoke to people in places like Northeastern on what devolution has done, the changes it has done in health in some of those places, then you will realize that it is better if we manage the finances well, the division of revenue of money is done well, we focused on accountability on the governors and the county governments, it is better with the health managed at the lower level, because it's nearer the citizens to hold them accountable. So we need to focus on the implementation of the full constitution, including leadership and integrity, and we'll be able to find things working well. Now, the CHPs and the gadgets. The CHPs, I'll tell you, when this issue came up, you remember they used to be called community health volunteers. And the push was to call them community health workers. And the county governments, we said, look, unless they are providing for money to pay them, if we call them workers and the county governments have wage bill sailings, some of the counties have already overshot those wage bill sailings. If you make them workers on minimum salary, where will the counties get the money from to pay them? That's why I was telling you that the issue of national government policies and legislations being developed, we now have to start auditing them for their financial implications for county governments. If they are not ready to provide additional money, we cannot allow them to create new structures that will require money, and they are not giving county governments the money to pay those structures. So that's how they ended up with the compromise. Let us now call them community health promoters, because the issue was, if you national government, you say they are workers, you know the labor courts will declare that they must be on minimum salaries. And you know you have even set a minimum wage bill sailings for us. If you are not giving us additional money, how do we pay them? Now, my answer to this is that if we push them to implement the primary health care fund and allocate adequate money to that, then it would be possible to say that the primary health care services, particularly at level 2 and level 3, will be able to raise reasonable money from which you can be able to pay the CHPs well. And that's what I'm saying. We must put light fires behind our elected leaders, particularly members of parliament who allocate budgets, that if you really want CHPs paid and you want to shift from curative services to preventive services, you cannot give tariffs that incentivize curative services. The tariffs we have now, the capitation they talk about is money allocated to what they call a primary care network, and then they say how that money is shared in the network to the various facilities in the network will depend on hospital visits and the diseases treated. That is going back to the curative approach, and they are not shifting to the preventive. So if we push for more investment in preventive services and CHPs are more in those preventive services, then it should be possible to address this and deal with that. And then related to that is the question that has been raised about public health services. I'll tell you, in the last 2 years I've spent in the counties trying to guide them on how to enact facility improvement financing laws that can enable the health facilities to continue keeping the money they collect and using, as it used to happen before the new constitution came, so that the money is excluded from going to the county revenue fund. And in that push, we have been saying money that is coming from public health services must be also treated as health money that should be retained at the public health unit to be invested in primary health care services. Now, the Facility Improvement Financing Act that was passed by Parliament, what Parliament, the national government did was we were going county by county guiding them, and counties were adopting those laws. So they said, oh, they're moving slowly, let us come and do a national law that will bind all of them. Then they came and picked the model law we were using for the counties. They went and changed some things here and passed it. Of course, in that law, they have not clearly come out on the issue of public health services. Now, unfortunately, when that law got into the Senate, the last minute, they changed the section 29, which had said the CEC for health shall make regulations. They changed and said each county shall pass its own Facility Improvement Financing Act. So again, we had to switch now to start guiding county governments on how to align their FIF laws to the national one. And after identifying what we saw as the broad uniform norms and standards established by that law, and we are insisting that one of those broad uniform norms and standards, especially if you look at that in the broad picture of the four laws bring about reform, which you want to shift to preventive, we are saying public health services must be treated as health money that must be recognized under FIF and be retained by the public health service units and used there. And I think if we do that, we might help in some of these issues that we are talking about. Now, minimum of 300. I have already told you that insurance will not pull enough money for us. Under NHIF, we had gone for 500 minimum. Now, in our quest for popularity, we went out there to say, sasa nimepunguza hiyo itakuwa 300. And yet in the law they have put there will be means testing.
So when many people go for means testing, they find they are being told pay 800, pay 1,000, and so on. So they are getting shocked and saying, the president told us it will be 300, ametupunguzia from 500, now it's 300. Let me tell you, if we pay 300, it will not give us a sustainable fund. Even 500 will not. And I can tell you, the means testing is not working because Kenyans have learned how to answer questions to lead to certain conclusions. Although we have been told the system is such that there is a period when it gives just a particular figure for everybody. So, but many Kenyans, you know, even when they go to declare for payment of taxes, they know how to answer questions to be declared as having not made profit. Unfortunately, in one meeting, the governor for Homa Bay told us the problem in his county, in her county at the beginning, was that people wanted to feel important. So, kiulizwa uko na gari? Yes, niko na gari. Alafu mwisho the bill inatoka kubwa sana. But as I said, that law is there now. But now we have finished a year. We can start pushing for amendments. My approach will be, since we have already pushed it and it is there, can we identify the problems and be determined to address them? Those that require amendments to the law, we amend the law. Those that require amendments to the tariffs, we amend the tariffs and see how to move on. So that is what I would like to say. Now, how are we planning to, the idea of 80%, my answer was earmarked taxes. It will be the easiest way. Earmarked taxes. If we earmark certain taxes for health, and we can put on very many things, maybe some on sodas, some on sugar, some on tobacco, some, the beauty products, even the what we were told even about what we were told even about Gambia on telephone mobile services, and then that fuel levy, we can be able to put together a big fund that can be used to finance health. But our problem, as I said, is not putting together the big fund. It is managing it responsibly. Even after we put that big fund together, we must look at how it will be managed responsibly. Thank you.
Thank you. Thank you, Prof. I think we had a question for Dan and also Dr. Kahura.
Well, okay, thank you. Well, I must first of all celebrate us as Kenyans. You know, NHIF was like the best in Africa in terms of history and evolution of health financing systems. And even some of the Asian tigers, Thailand, Singapore, Malaysia, they attest to coming, visited here, and they improved what we had. And look at how far they've gone to get to UHC. So we do some good things, but we keep on abandoning ship and restarting the magic again. So on the issues of SHA not covering and registration, well, we were registered in NHIF, and because of data transfer, we were supposed to verify and validate our information on the other side, because they claimed there were ghosts and many ghosts in the system, and the only way to clean out those ghosts was to come in and verify your fingerprints or something like that. But even right now, as we're speaking, that is not yet fully out. So I don't know. It's the aspects of new project, new funding, new businesses, new tenders, and we have a corruption monster in the country, not just at the national space, but even the county governments. And even in to address one of the questions as who does it better? Is it national or the county governments? During the pilot phase of HC, the reports as they are written, they claim the county governments are not capable of trusting or doing the best for their people at the county levels. And these are the MCAs that they pass the budgets. And that's why now we have the bill that ring fences the monies at those points at the hospital so that it doesn't go out. because once it goes to the county assembly, the governors move out the money to flowers, to painting buildings, and to conferences, and they don't invest in the healthcare. So the Facility Improvement Fund Act comes in now to control and lock the money at those facilities, so that now, as patients accessing public services can enjoy and appreciate. And now that's when the national government comes as bigger supervisor to say, now I'll pay you when you provide services, and they give a tweak of a capitation model that you provide services and then I'll pay for them, lock the funds, improve your services, and attract more people in that level. So we hope it works, and from that theoretical explanation. On the question of doctors, nurses, and CHPs. Now, CHPs, what you're doing is a very important job. And I have heard, and it is going to come. Workers world over always complain about decent work. And that's why, as a union, KMPDU, we speak about what we do and that they need to be remunerated as we're supposed to. So it will come a time that you'll have a CHP union. In other countries, community workers, they have their unions as public workers. And they push for decent benefits and remunerable terms that are easily identifiable, not that stipend that you get. A day is coming in the next maybe few years. You organize yourselves, push for your rights, and do your best that you're supposed to do as workers. Promoters, it's just a fancy word. You're workers, whatever you do, you're recognized as such from review. On the aspect of how many strikes should we do to improve this and whether shift funds can be used to pay doctors. Well, during devolution again, counties got money, but this money has not been categorized into what goes into HRH, that is healthcare services and salaries, equipment, and other services in healthcare. So everything has been looked at. Let's give counties this money and let's keep this much money in the national space. And the counties will sort themselves out. Now, sorting themselves out has not happened. So they keep saying wage bill is too high and healthcare is taking too much. But this is salaries. But how much goes into equipment? Equipment has already gone into one tender, mess 1. There's already mess 2 that is to be paid by SHIF. And mess 2, when I say mess, it's, well, maybe mess as it means, but it's managed equipment services. That will give you equipment from the national space, and you, the county government, you will pay some tax, like hire purchase. And you'll pay from the funds that you collect at the county government. But it is the national people, the ministry, and other players that will manage that. Now, the county government, maybe at the COG, they are quiet when all this is happening. They know it is happening, it's not right. We should have devolution working, but no one is speaking to it. And when they do, some of the governors are told, keep quiet. So there's also politics at the COG. So issues don't come out as clearly as they should for us to benefit as citizens at the grassroots level. So a lot needs to be taken out on that. On the issues of practitioners' licenses and how much is to be collected to go where. Now, there are licenses that are paid nationally. Those go to improve service regulation. Then there are county government that they want to charge licenses to either improve collection at the counties because they say they provide garbage, they provide roads, they maintain all that. Well, as workers, as facility owners, we keep saying that those funds they're not adequate. What the county governments ask need to do is to improve their service delivery patterns. So whatever they collect and charge as levies can be earmarked or taken to where they're supposed to go. But SHA, it's not possible to have those collections going there and go towards licensing and trying to improve. There are different kind of systems, regulation and service delivery and a SHA. There is one question that one of the attendants has asked on the issue of trust and negligence and misdiagnosis and overpricing of fees. Now, this is somehow different from SHA. SHA is all about paying for services and making sure that you don't use your own good money to access services. Now, the other experience is when someone misdiagnoses you. That doesn't fall under SHA. It falls under someone else, which is the regulator, who has a board and a tribunal that sits to listen to those complaints of misdiagnosis. And when that happens, the matters get taken out and paid out differently in a different panel. So the aspects of overpricing of fees also happens in that tribunal. So overpricing, misdiagnosis, different tribunal. That's the Kenya Medical Practitioner and Dentist Council. So it's separate from SHA. But even as we're speaking right now, they are creating another law, they say, to separate doctors' licensing and facility licensing. And our facility licensing will now take up also matters of quality healthcare services. So that if you have such kind of complaints about a facility overbilling you or a doctor misdiagnosing you, you can take that complaint in there. So we hope that the law will come and we'll be involved in it and we'll improve it towards the benefits that we need to have. So something important that you also need to know is that in Kenya, we have about 28 health laws. There are too many for all of us to follow and know what is going on where and where. And it's only in 2017 we had the first organized law, that is the Health Act of 2017. So it tries to streamline, but it still leaves out some sections that maybe in the future we have other amendments to streamline the different areas that are happening in the space. So there is a lot that we could talk about, and I keep saying that we need to continue having these conversations. I heard someone saying that doctors or workers and nurses, they do not understand all this. We do understand. We were only complaining, and we'll keep on complaining when the cars are not fueled, when the drugs are not brought, because there's nothing we're doing down there at the county levels when the services that we're supposed to offer are not realizable to you as a people. We merge that, but we keep to complain. Like the first 2010 to 2015 strikes were about quality, but no one cared. The workers, the citizens, we complain, but the citizens don't join us. So if you realize that, then you don't really need to complain about drugs. No one cares about drugs. Let's just complain about our pay. And over time, it's been pay, but sometimes you tell them, even the pay is not commensurate to what you're supposed to do. So improve the services so that everyone is happy. So we speak as workers to still merge your issues as citizens so that we can all benefit in that journey. It's not a journey that the doctor is removed from the system. The patient is at the center of it, and we all must move together. The doctor is happy, the patient is happy, the governor is happy, the MCs are happy, and the system is working. So that's what we aspire to. Thank you.
The question was when we are coming. I am happy that ICJ has come in the health space. I'm sure, as she said, we need to pull all our efforts and resources together and reach out to communities because PHM can't do it alone. Yes.
I would also like to make an observation. Those people who have gone to hospitals, there's something that has been introduced, e-citizen. Every payment you make, there's something topped up, 50 shillings. So when you go for your consultation, you pay 50 bob. When you go to get your drugs, you pay another 50 bob. When you go for your x-ray, you pay another 50 bob. So on top of that SHA, after paying your SHA, you're still being charged extra for every service that you receive in the hospitals. So we are wondering, you've paid your insurance, yet for every service that you're attending to, even if they need to charge you, they'll charge you the consultation, which is 1,100. But when you're doing your M-Pesa transaction, there's a 50 bob charge added on each. So we are also asking the same questions. Why am I paying for SHA? And then also for every other service that I'm getting, I'm being charged 50 bob. So by the end of the day, when you're done with all those transactions, because you cannot do one, you have to, for each one, pharmacy, x-ray, it's a process. You'll find yourself even paying up to 300 extra. So we need to find out, if I'm paying SHA, let me not be charged extra.
Thank you. I think we do not have much time, and I know the conversations are getting interesting as we move along. But I will allow at least 3 people to ask their questions. And please, when you ask your question, do not keep it compounded. Be very clear with your ask, and then we will finalize the last response by the panelists.
I'm Sylvia. So my question is, we have seen the fact that we are ready to ask for accountability to the government. We have seen the psychological trauma that comes with the arrest for those people who speak out. So to the legal experts, do you think that the only way we are left with to ask for accountability is by doing petitions in court cases? And also we have seen how
the government has ignored the courts. Thank you.
Good afternoon, everyone. I'm Jemima Mudhoni from Health Rights Advocacy Forum. As we sit here and deliberate on health financing, the SHA-SHIV things, right now in my village, somewhere near Wamunyoro, there is somebody seeking health services. And my concern, and I wish to address this to Prof because of where you sit at the Council of Governors, is that there is limited investment in ICT infrastructure, especially in rural primary healthcare facilities. Someone mentioned that there is a lot of wastage in these spaces because every financial year, I see my MCA recarpet Amaram Road. I see them push street lighting as an agenda. So repurposing, counties have the finances, but can we see more focus on health infrastructure investment? We are seeing the same under the national government, CDF. And you see MPs rush to have ICT hubs all over. These ICT hubs are not providing any internet access to primary healthcare services. And this is a concern to me because as SHA happens, these facilities are required to raise e-claims. For you to do an e-claim, you need a laptop, a computer, an internet connection, and a dedicated human resource officer for you to realize this. So even as counties continue to provide services, this money is not coming back in. So, and then the reaction of the counties is to increase the out-of-pocket expenditure. So much as I'm contributing for SHA, then counties are not claiming, and then what do? They need to keep the services running, then they increase out-of-pocket expenditure for me. So it's a loss for contributors. Thank you.
Good afternoon. I'm Philip Njeroge from Kanko. Having heard from the advocate from IPF, mine is just a challenge to all of us. Now that we anticipate that there will be the SHA report, how do we intend to go about it? Do we need to have a working committee which will interrogate the document as a reference document of how we can petition Parliament on some of the things which will come out of that document?
Thank you. So we'll get responses from the panelists and then we move to the next stage.
Thank you. Now, the reason I gave that pyramid, if you look at level 2 of the pillars, it was deliberate because I know that when politicians want to allocate budgets, they want infrastructure. And to them, infrastructure are 4 walls. Puts up 4 walls and says, nimewajengea dispensary. They don't understand that for that to be a hospital or a health facility, you need their health workers, you need to budget for that, you need their health products and many other things. And that's why my emphasis is that we need to work on understanding these pillars as things that are interconnected and learning how to help those who have been assigned certain responsibilities under the law to understand some of these things. It is true what you're talking about, the MCAs will go for that. Everybody saying, I want a health facility for my area, because then they are looking for something they will say at the campaign, I did this, I constructed this for you. And the reality is that there are a number of counties that have such facilities that have not been operationalized because these other things are missing. And that's why we need that interdisciplinary understanding. And you come to the members of parliament, when this thing called CDF was introduced, it has created a sense of competition between members of the National Assembly and the county governments. And the loser are the citizen. So we have refused to organize our things and services with our eye on the citizens. The eye is on which leader is managing which money. And the reason is because when you are managing the money, you can do your own things here and there. So we need to focus on that. Now, a last thing I want to talk about, again related to that, is that my learning in the past 4 years engaging in the health sector, which I came in as an expert in constitutional law and devolution, and those who took me to Council of Governors said, we want you now to focus on the devolution of health and see how do we get it to work. It has helped me to understand quite a lot on health. And I can tell you, we do have a lot of challenges, as Dr. has said, the issues of even HRH, how we manage HRH in our devolved system are huge issues. The biggest problem we have as a country is that we are never willing to say, okay, we have started this journey. Can we continuously identify challenges and fix them? We never want to do that. That's what the problem is. But the bigger issue I have learned is that in this country, we have been operating, even as professionals, in silos. We hardly seek to understand each other across the silos. So when I came into health in 2021, in 2020 December, we will convene meetings of the CECs for health, or chief officers for health, or directors for health. And most of those meetings will be about complaining about what is not happening. Or those meetings will make policy decisions. And next time you meet, those decisions have not been implemented. Why? Because there was no money. Until one time we said, no. Why don't we try a joint meeting of CECs for health and CECs for finance, so that they start understanding each other. The finance people start understanding the challenges of health and why they're asking for more money and why health is not like the rest of the departments. And the health people also start understanding even the budget cycle. A lot of the citizens, we are saying they should do accountability. Most of the citizens come into the budget cycle at the stage of the budget, but they don't engage at the stage of coming up with the work plan. You see, you begin with a shopping list. These are the things we want. Then you prioritize. Out of these things, we cannot manage all of them, so we are going to prioritize these 10. Then now you say, these 10, can we budget them? At the stage when those things are being put in the shopping budget, a lot of the citizens don't engage. A lot of the health workers are not aware, so they don't engage. They'll come to realize when now the budget comes out on the things that have already been prioritized. And they feel, but to us, this is not the priority. The priority should have been this. So that's why I'm saying we need to start some discussions that help us to have interdisciplinary understanding, because the health services we are providing from that picture, health is not just an issue of the clinically trained health workers alone. It is also an issue of health economists, of finance people, of the legislators who pass these budgets and all that. And we need to get all these people understanding some of these things. And our biggest problem in my latest argument in constitutional law is that I think for a long time, we constitutional lawyers and constitutional makers have not recognized the important role of public finance management in a governance system. And that's why in our country, the treasury operates like a government within a government. And if you talk to some ministers, they fear the Department of Treasury. They cannot question them because they will not give me money. Or they will allocate me money and only release it when the financial year is about to close. So we need to ask ourselves, what is the role of public finance in government? If you conceptualize the power of the state, a lot of times traditionally we look at the legislative power, the executive power, and the judicial power. But I want to tell you, the real power of the state lies in the financial power of the state. Who controls the public finances? And who controls the second power is the instruments of violence, the state apparatus of force. And you know, when the Gen Zs went on the streets, they were complaining about mismanagement of our public finances. Because the public finance is still overly controlled by the executive through the treasury. Go to the counties. Even the county treasuries are very powerful. They're giving health departments a lot of problems. We need to address that. And then when now the government had to confront Gen Zs, what did they come with? The state apparatus of force. So the executive controls the executive power, controls the public finances, controls the state apparatus of force. And I normally conclude by telling people, in our country, if you told an MP or a senior government official, your son should go to the army or the police, they feel very important. Why? My son, I'm a senior person. But in Uganda, Museveni ensured the son went to the army and he has promoted them to the highest level because he knows you can go and drop your papers in a ballot box. But if he has the gun, he can still remain in power, isn't it? Those two, going forward, how public finance is managed and how the state apparatus of force are managed are the things we need to start focusing on. In this constitution of ours, have we dealt with them well? This Public Finance Management Act, the way it was done, is it undermining the constitution or is it consistent with the constitution? The Public Procurement and Assets Disposal Act, those two are the major, the Public Finance Management Act and the Procurement, they are the major public finance management laws. And I can tell you, they are at the center of our problems today. We need to start addressing that and ask ourselves, what do we do? Last year, in December, or was it November, when the Supreme Court was having a conference of the Supreme Court, I was a panelist, and I was telling them, now we are getting very many cases in court raising issues of public finance management. Do the lawyers understand public finance? Do the judges understand public finance? When we started the new constitution, Mutunga started the idea of employing researchers for judges. All of them have been lawyers. And I was telling them, can we now start thinking beyond lawyers when we are talking about researchers for judges? Because now litigation is moving on this issue of finance. Do the judges really understand public finance? My good lady here, you would be a good advisor to them.
Thank you. I think the last question was really about the options available for accountability. I think one, Parliament has been discussed. Citizen mobilizations through our various formations. Social accountability, we cannot let that go. We start holding government accountable at the lowest level possible. Of course, courts have an obligation to protect our fundamental rights. So whenever necessary, whenever possible, let us go to courts, but also let's not forget there are audit institutions, as we've mentioned, including Parliament, including the Auditor General. Let us also use all this. The long and short of it is that let us be aware of what is happening around us and let us question. Finally, let us expose what we believe is wrong. Exposure is one way that when you see it happening, expose it. That is when we will reduce the appetite for the wrongs happening in the community. Whether they are abductions, whether they are threats, expose them. That is when you reduce the appetite. Thank you.
Thank you very much. A round of applause for our panelists for giving us very good insights on health governance in Kenya. Now, I just want to take the next few minutes to quickly go through the final reflections as I was recording and just seeing how the conversations were going. Then after that, you can see this banner has what we call the Afya Bora Platform, Right to Health Dialogue. I want to explain to you what this platform is all about. So from the reflections, one of the things that has really come out clearly is the need to rework our funding models in terms of budgetary allocations, to rethink Kenya's health financing model to ensure sustainable and equitable funding for healthcare, and this will include addressing inefficiencies in revenue allocations to county and prioritizing preventive care and ensuring that health financing aligns with community needs. And we all remember Prof mentioning that perhaps we need to think about earmarking some taxes to go to healthcare. Then the other issue is the need for us to hold Parliament accountable for its role in safeguarding the right to health. Legislative oversight should focus on budget approvals, policy formulation, and ensuring that public funds are directed towards strengthening healthcare infrastructure, workforce, and service delivery. The other thing that has come out strongly is in terms of leadership and governance in health. We also, the demonstration by Prof, and having noted that without proper leadership, which is the foundation of enjoying our rights, then we'll be in a vicious cycle and Kenyans will not benefit. So effective leadership is critical in ensuring health systems function optimally. Governance structures must be strengthened to promote transparency, efficiency, and responsiveness in the management of healthcare resources and service delivery. Then there are also issues of accountability, and we need stronger accountability frameworks which should be implemented to track healthcare spending, service delivery, policy implementation, and this will include clear monitoring systems, independent audits, and public participation in health governance. For community, there is need to engage with the community effectively. Community involvement is vital in shaping healthcare policies and programs. Strengthening grassroots participation ensures that healthcare solutions are context-specific and responsive to the needs of diverse populations. And then there is also a greater need to amplify the voices of the community in both urban and rural areas to ensure that both urban and rural communities have a voice in healthcare governance, which is very essential. We also need a platform for civic engagement, public consultations, and community-driven advocacy that should be enhanced to influence policy decisions and demand better healthcare services. I know there are so many that we need to focus on, but I thought these were important, and because of the live streaming and these sessions being recorded, we'll be able to review the videos and get more, even as we do our final report, which we will share with all stakeholders. Now, to the Afya Bora platform. I think over time, all of you have attended meetings which have borne no fruits. In terms of, you've been called to a meeting, maybe it's a right to health platform, and then from there you do not know what happened to maybe the recommendations that were given in that meeting. There are no follow-up mechanisms. So it could be you as a paralegal being invited to such meeting, and then the next time maybe you'll hear anything of this kind is in 1 year's time, maybe invited by a different organization. So it is out of that that we thought of creating a platform for continuous dialogue. Allow me to just share a bit of story, even as we end this. So I want to use an example, and I know we have so many stories of how people are not getting the right healthcare services that they need. So Mama Boga sat quietly outside a health facility in the rural area, clutching her referral papers. Her child had been diagnosed with a treatable condition, yet she faced an insurmountable challenge. Access to proper healthcare was either too costly, too far away, or simply unavailable. Like thousands of Kenya, she was caught in a system plagued by inefficiencies, inadequate resources, and policy gaps. It is such stories, and even Grace is a living testimony, that has inspired us to create what we call the Afya Bora Platform, which will be a collaborative initiative aimed at transforming the health rights landscape in Kenya. And so today we have had representation from civil society, academia, paralegals, medical profession, and the community at large, coming together for this stakeholder forum. And to us, the Afya Bora platform will be a very good initiative designed to bridge the gap in health governance, facilitate informed advocacy, and push for systemic reforms. The platform will serve as a dynamic space where stakeholders can engage, collaborate, and respond swiftly to emerging health governance challenges. Kenya's healthcare system, we know, is persistent with hurdles, from weak policy implementations. Prof was mentioning that we have so many laws that are good and the intention is good, but now in terms of implementation, it's very lacking. So the Afya Bora platform will seek to address some of these challenges by creating a centralized space for knowledge sharing, policy discussions, and advocacy coordination. So one of the things that we will develop is a centralized online repository for health rights advocacy. And the key opponent for this, it will be an open access online repository, which will house research papers, reports, case studies on health governance and policy. We have litigation experts in the room, so the repository will also have ongoing litigation and legal resources, including some of the resource or knowledge products that have been published by ICJ. And because this will not just be an ICJ platform, we are also going to work with like-minded institutions to ensure that we carry this work together. The platform will also have best practices and advocacy tools to support evidence-based lobbying efforts. Another thing that the platform will offer, because we want this to be a continuous dialogue, a continuous conversation where we keep these engagements alive. To ensure continued engagement and action, the Afya Bora will host quarterly dialogue series, which with diverse stakeholders, including policymakers, legal experts, and frontline health workers, to convene to discuss pressing healthcare governance issues. So this is just first of that meeting, and we are committed to continuing to hosting such in the future. So our call to action, we invite civil society representatives, medical professionals, legal practitioners, community members to join our movement, contribute resources, and also participate in discussions that shape the future of healthcare in Kenya. Now, I know Hamisi asked where civil society is in terms of engaging with the community. So there is some work that ICJ is currently doing. So far, we have gone to Makueni. We have also been here in Nairobi, in Dagoretti, and also in Kariobangi. And I am glad that one of our facilitators is here, Mr. Bilasio, who has really been helping us to mobilize the community so that
we can engage and also just create awareness around the transition. So the journey has not stopped. We will continue. From Nairobi, we intend to go to Narok, to Kwale, Isiolo, and also Kakamega. So this is just the pilot phase, and we are hoping that through the issues that are going to emanate from visiting those regions, we will be able to come up with a report capturing the issues, and which through the Afya Bora platform we can discuss with the different stakeholders that will be there, and then we can find practical solutions. So with that, I think I am done. I want to thank everyone for their time. I know the discussions have really been interesting. And I want to invite my colleague, Christine Akinyi, to come and give us the closing. After this, we will have lunch together and also just an opportunity to continue engaging. So the vouchers are just outside there. So as we'll be leaving, we'll get our lunch vouchers. So Christine, karibu.
Thank you, Geoffrey, for the good work. So my role here today is just to give a vote of thanks on behalf of ICJ. It has been such an honor to be part of this wonderful event. On behalf of ICJ Kenya, I would like to extend gratitude to our esteemed speakers, Grace Mulei, Dr. Kahura, Dr. Mutaha, Martin, Grace, and Gladys and Dan Wala. Thank you so much for your time and for your eloquent submissions. I believe everyone here has learned something new. Yeah. Then I'd also like to thank the ICJ Kenya team who have handled the event throughout the day, led by our Executive Director, our Deputy Executive Director, Geoffrey, and the Economic Justice Program. Thank you so much for your effort. I believe it has paid off. Then finally, I would like to thank all of you present here for making time to be with us today and help and making this event a success. It will not have been an event without your participation. Thank you so much, and we look forward to engaging with you more under the Afya Bora platform. Have a good afternoon.